pregnancy is our shared goal and mission. Your presence here today reflects a deep commitment to advancing maternal and fetal care, a cause that demands not only a scientific knowledge but a human compassion. In obstetrics, we are trained to expect the unexpected, and that's more than evident in high-risk pregnancies, where mother's condition, fetal well-being, and circumstances around them test our skill, judgment, and empathy every day. This conclave is not just a scientific gathering, it's a platform for transformation, a space where we exchange ideas, challenge assumptions, and reaffirm our responsibility to ensure safe motherhood no matter the challenge. What makes today special is the diversity of minds we bring together: obstetrician and gynecologist, anesthesiologist, neonatologist, endocrinologist, and physicians, all united by one mission: to reduce maternal and perinatal morbidity and mortality. Let's utilize today not just to learn, but to reflect, connect, and recommit. Because behind every high-risk pregnancy is not just a diagnosis, but is a human story. And it's a privilege to share, help shape that story towards hope and healing. May I now request our esteemed guests of honor, Dr. Balamba ma'am and Dr. Shantakumari ma'am, to please come on to the dais. I request Krishna Kumari madam to please join us on the stage.
Full stage. Whenever people hear full stage, if only they are talking, fully done. No, means only that means take. No.
Nikki, why you from up there?
With a boy, put the lamp.
I welcome all the dignitaries on the stage. Thank you. We now move on to the auspicious lamp lighting ceremony, symbolizing the illumination of knowledge and wisdom. May I request all the dignitaries on the stage to kindly light the lamp and formally inaugurate the conclave.
Bro!
thank you to all the dignitaries for making this moment truly memorable. I request all to be seated. Our guests of honor truly don't need any introduction, for their names are synonymous with excellence and service in the field of obstetrics and gynecology. But allow me to take this opportunity to briefly highlight their incredible journeys. First, we have Dr. Balama ma'am with us, a legend in the field with over 56 years of experience in gynec and obstetric practice, a proud alumni of Osmania Medical College. Madam is also a fellow of Indian College of Obstetrics and Gynecology and a respected member of various national societies. Her commitment to compassionate care, education and surgical excellence has shaped generations of doctors and transformed countless lives. Words truly fall short to describe the depth of her contribution, Madam. Next, we honor to welcome Dr. Shanta Kumari Madam, a renowned gynecologist, laparoscopic surgeon, professor, and global women's health advocate who has balanced clinical brilliance with leadership and academic excellence. Madam has served many prominent roles from FOXI President 2021 to 23, Honorary Treasurer FIGO 2021 to 23, Chairperson of ICOG, Vice President of FOXI, and FIGO representative working against violence towards women. Recognized with fellowships from RCOG and FRCPI, Dr. Shantakumari Madam continues to inspire the medical community with her tireless dedication and visionary impact. We are truly privileged to have such trailblazers among us today. Now, I request Dr. Balamba ma'am to address the gathering.
Good afternoon, everybody. It's a pleasure to watch all young obstetricians and gynecologists here, so many generations younger than me, talking about women's health and obstetrics. The most important thing I feel to be an obstetrician, a good obstetrician, I won't say an excellent obstetrician, a good obstetrician, is to be committed and to be available for the patients 24/7. And that is the reason, most postgraduates nowadays want to become fertility specialists or endoscopic surgeons and don't want to take up obstetrics. And in course of time, if we continue like this, I think slowly the obstetrics will go into the hands of the midwives, which was there when I was a student. And we are talking about high-risk pregnancies, but all obstetricians know the so-called low-risk obstetric patient also can become a high-risk patient in no time. In the labor room, you think everything is going on well, the patient has delivered, and suddenly you turn your back and you go after 5 minutes to look at the patient, then she may be lying in a pool of blood. Or she might have even died. Amniotic fluid embolism can also occur. So we have faced all these things, and we have faced all these things when we were young, when there was no consumer forum affecting the obstetricians. But now I think you young obstetricians and gynecologists have to think of even the consumer forum and the medical legal issues also. So I think, one has to tread very carefully. And this is where, you require a senior obstetrician's guidance also. And then, I would appreciate, because you see, of late what I find is all single obstetrician run nursing homes are closing down. Because it has to be a group practice. Because you can't be 365 days, 24/7 available to patients all the time. Everybody has family commitments. They have to look after that also. Apart from, you need some break from your work also, so that you get rejuvenated and come back and look after your patients. So I think, this concept of group practice also has to be encouraged. And my advice to young obstetricians will be friendly with each other. Don't cut down your competitor. And then don't ever talk ill of any obstetrician or any doctor for that matter. And don't say anything to the patient when she brings some prescriptions from some other doctor and you know it is wrong, but don't express it. Because that is going to go a long way to foster, what should I say, sisterhood amongst the obstetricians, and that would be my advice. Thank you very much.
Thank you, ma'am, for your inspiring words and gracious presence. I now request Dr. Shantakumari ma'am to please address the gathering.
Namaskaram friends, it's indeed a pleasure to be here, and I bring warm greetings from FIGO as the FIGO treasurer and from Foxy and Obstetric Society of Hyderabad. I think we should congratulate Medicover team for coming forward and organizing this academic program. It's quite a big program I've seen. Almost it's up to 8 o'clock in the night. Very rightly told, Dr. Balamba, Madam has very clearly said what is the role of an OB-GYN in today's practice. My dear friend Krishna is here. You know what, we were just talking about now, in the present day, what is happening. What do you see when you are going around in Hyderabad? Hospitals, what do you see? I just visited an IVF center and came. In the past 1 year, I think I have inaugurated more than 10 IVF centers myself in Hyderabad. So that shows that the present day, all the young girls and boys who are taking up OBG want to become only infertility specialists and IVF specialists. But let me tell you friends, the future is for obstetricians. We need obstetricians to deliver our mothers in India and globally. And world over, we realize that now it's time that obstetrics is given its due importance. So all of you who are doing obstetrics and all the youngsters, I find a lot of youngsters here, even if you feel IVF is looking glamorous, in the coming decade, let me tell you, the most glamorous field will be obstetrics, because there's going to be a dearth of obstetricians. So take the opportunity, become good obstetricians, and try to help women and have a normal birthing experience. We find globally now we are all worried whenever we go to any meeting at the WHO or any other partner meetings. The main focus are on two things. One is the rising incidence of cesarean section rate, and the other is the cervical cancer burden. So I think the onus is on all of us to try to see that we help women deliver naturally, the primi-gravidas especially. Kindly see that you give the maximum level of care for the woman to deliver naturally if there are no problems. Obviously, we want the mother and the baby to be healthy. So try to see the best care and the best outcome for the primi-gravidas. Only then will this cesarean section rate start seeing the decline in the next decade. It will take another decade for it to at least start the decline. And you know, whenever I go to any of the meetings, I'm very, very particular. I wear only saris, any international big meetings. So the minute they put up the statistics, cervical cancer statistics, after Nigeria, India comes. They all look at me. Cesarean section rates, they put along with the South America, India, and in India they put the sub-classification, they put Telangana. I am so proud to be from Telangana, but unfortunately at that minute I feel so bad because we are topping the level of cesarean section. So this is an earnest request from us to all the obstetricians to try to see that we deliver our women with the best possible outcome. So all of you, the younger generation OB-GYNs, can you all put up who all are OB-GYN specialists here? Obstetric specialists. Hand can go up a little in the audience. Hardly. Rest of you are not doing OBG? Obstetrics, no? Or there are other specialties or IVF? How many IVF people are here? Okay. So there must be. So I think we have got a very young group of obstetricians here. Kindly see that you help mothers deliver normally That doesn't mean let any mishap happens. The best possible outcome with the less morbidity to our babies and mothers is also very important. I think this is a message which I'd like to give you all, and look forward for cooperation from your side. You're doing academics, you're talking about the medical aspects, you're talking about complications, but the most important is the way we are dealing with our women and patients and our colleagues. As already told, try to have a good, harmonious lifestyle with your colleagues. I think that is the best way forward, because we have found that mental health issues are taking the forefront in the physician's life. So I think we have to be with each other to reduce the stress of mental health. Of course, now because the corporate culture has come and so many other aspects are there, with all the medical negligence aspects, everything, litigations, we are scared. So at least the best or the least we can do is to have good interpersonal relationships, and that is most important, and make science and evidence-based studies the basis for your treatment. And at the same time, take a little time to actually keep your data, safeguard your data, and produce them, publish your data, publish your work, because that is one thing which we are lacking in our country. I think that is what the heads of the institute should see. Encourage your consultants to publish their data, and I think that is very important, because that will make the world see what excellent work we are doing in the country. So wish you all the best and happy learning in today's CME, and it's going to be a long, long day. I'm sure you'll get some tea and coffee in between, and wish you all the best.
Thank you, ma'am, for joining us today and sharing valuable insights. I now Sir has a vast experience in pediatrics and neonatology and would be sharing few words today. Thank you, sir.
Respected dignitaries on the dais, dear friends and colleagues, it's nice to see you all here. It's such a wonderful afternoon today. I hope you all had nice lunch, and we all have a lot of topics, interesting topics this afternoon. I'm sure you all enjoy here, and I thank you all the organizers for organizing this event. And thank you, Madam, for accepting our invitation and coming here. Thanks a lot. Thank you all.
Thank you, sir, for addressing the gathering. I now request Mahesh Deglurgar, sir, Chief Business Officer, to kindly felicitate Dr. Balamma, madam.
Before that, I just wanted to say real thanks from bottom of my heart to the legendary teacher of the state or Telugu states, Balamma madam, for being here for this program, and also great to have Shanta Kumari madam to be here. We are blessed to have Balamma madam and Shanta Kumari madam for this wonderful program, a CMA program. It is difficult to get her time. I have been seeing Balamma madam for 30 years, right from my basic executive level. I have been meeting madam, and the kind of patients or my aunties are delivered by her. I really feel very proud about Balamma madam accepting her valuable time and being for this CME program. Thank you, madam. I request Mr. Prasad, Center Head, and also Mr. Dr. Venkat to please join me for this presentation.
Bro, కొంచెం sorry.
Move it straight to be in the center.
ఓకేనా?
Okay, ready, look you. Smile, smile. Done, sir. Thank you.
I now request Dr. Satish Kailasham sir, Group Medical Director, Medical Hospitals, to kindly felicitate Dr. Shanta Kumari ma'am.
Okay, ready, look you. Okay, done, thank you. White ले लो, white ले लो. Thank you, thank you. Yeah, okay, ready, look you. Done, sir, thank you.
Thank you, Dr. Balama ma'am and Shanta Kumari madam, for honoring us with your presence. I now request all the dignitaries to please be seated so that we can continue with the academic session. Thank you.
అది 100 ఉంది ఉంటే కనుక చెప్తాను ప్రిన్సిపల్.
As we begin our today's session, our central theme remains excellence in high-risk pregnancy care. This domain requires meticulous attention, interdisciplinary collaboration, and unwavering commitment. Over the course of the day, we will hear from leading experts, exchange valuable insights, address existing challenges, and explore innovative solutions for improving the outcomes in high-risk pregnancies. On behalf of the organizing committee, I once again extend a very warm welcome to all the delegates, speakers, and guests. May today be filled with meaningful conversations, new ideas, and renewed inspiration. Wishing you a productive and enriching day ahead. Now we move on with the sessions. I request Dr. Trisha to continue. Thank you, ma'am. We now begin a session focused on one of the most critical contributors to maternal and perinatal morbidity and mortality, hypertensive disorders in pregnancy. From gestational hypertension to preeclampsia and eclampsia, these conditions demand timely recognition, accurate classification, and prompt intervention to ensure safe outcomes for both mother and baby. We are pleased to welcome Dr. Raga Reddy, consultant gynecologist with rich clinical expertise and academic depth, to give a comprehensive presentation on the clinical spectrum of hypertension in pregnancy, its classification, screening, and investigations. Following this, we will hear from Dr. Meenakshi, consultant gynecologist with extensive experience in high-risk obstetrics, who will take us through the diagnosis and management protocols tailored to the varying degrees of severity of hypertensive disorders in pregnancy. Moderating this session, we have Dr. Daya Vaswani, our Senior Consultant Interventional Radiologist, Dr. Shilpa, our Consultant Anesthesiologist, Dr. Shravani, our Consultant Physician at Medicover Hospital, together who will steer this discussion, ensuring a thoughtful exchange of ideas and a productive session. Please join me in welcoming Dr. Raga Reddy, Dr. Meenakshi, Dr. Daya, Dr. Shilpa and Dr. Shravani as we begin this important session on hypertension in pregnancy, diagnosis to delivery.
Good afternoon everybody, I am Dr. Raga, Consultant Medicover Women and Child. So today I am going to discuss about my topic is screening to management of comprehensive pregnancy related hypertension. Hypertensive disorders in the pregnancy are a group of conditions which is characterized by elevated blood pressure during pregnancy and classification of hypertensive disorders in pregnancy. It is classified as chronic hypertension where the BP is more than 140/90 before 20 weeks of gestation and there is a known history of hypertension before the pregnancy and may persist beyond 12 weeks postpartum. Then white coat hypertension where the BP is 140/90 in the clinic setting and it is less than 130/80 mm of Hg at home. And the masked hypertension is where BP is less than 140/90 in the clinic and it is more than 135/85 of Hg outside the clinic settings. And gestational hypertension where the BP is more than 140/90 mm of Hg after 20 weeks of gestation without proteinuria or end organ damage, end organ dysfunction and resolved by 12 weeks postpartum. Preeclampsia. The preeclampsia is when the BP is more than 140/90 after 20 weeks and with any of the following: proteinuria or organ dysfunction, that is renal, liver, hematological, neurological or pulmonary edema. Preeclampsia superimposed on chronic hypertension where chronic hypertension with new onset proteinuria or end organ dysfunction after 20 weeks. Eclampsia, preeclampsia plus new onset of seizures not explained by any neurological condition. HELP syndrome where hemolysis, elevated liver enzyme, low platelets can occur with or without overt hypertension. So the newer classifications are ACOG 2020, ISSHP and FIGO 2021 where it emphasizes on ISSHP 2021 and FIGO include fetal criteria, that is fetal growth retardation and uteroplacental dysfunction as a part of preeclampsia diagnosis. White coat hypertension and masked hypertension are now clinically recognized by ISSHP and FIGO. Focus has shifted from maternal and fetal complications rather than BP and proteinuria. So there are the terms hypertensive emergency and hypertensive urgency, where the hypertensive emergency where the BP is more than 160 by 110 with signs of acute target organ damage, and hypertensive urgency where the BP is severe, that is 160 by 110 without end organ damage. The symptoms like headache which are present in hypertensive emergency are headache which is mild in hypertensive urgency, visual disturbances, chest pain, oliguria, epigastric pain, altered consciousness, pulmonary edema, and end organ involvement like CNS, liver, kidneys, eclampsia, health syndrome, acute renal failure, or pulmonary. So, prevalence in India, it constitutes about 10 to 50% of pregnancies in India, whereas gestational hypertension is about 5 to 6%, preeclampsia is 2 to 7, eclampsia is 0.5 to 1%, and chronic hypertension is 1 to 2%. So it contributes to 10 to 25% of maternal deaths in India, and it is a major contributor for preterm births, intrauterine growth restrictions, stillbirths, and neonatal deaths. So it is higher prevalence is there in rural and rural-resource settings due to delayed antenatal care, inadequate screening and management, and nutritional deficiencies. So there is slight increase in detection rates due to better antenatal surveillance. Urbanization and lifestyle changes may be contributing to raising chronic hypertension cases. So the government programs like Janani Suraksha Yojana and Lakshya aim to improve the maternal health. In spite of all these challenges remain in early detection, referral, and standardized management protocols, especially in rural India. So the risk factors are classified into two groups, that is modifiable, non-modifiable risk factors and modifiable risk factors. The non-modifiable risk factors are the primary gravida, that is first pregnancy, maternal age less than 18 or more than 35, family history of hypertension, history of hypertensive disorders in pregnancy, in prior pregnancy, multiple gestation, that is twins, triplets, and autoimmune diseases like SLE, asthma, and genetic predisposition. And modifiable risk factors are obesity, high-risk pregnancy, high pre-pregnancy BMI, sedentary lifestyle, poor nutritional status, pre-existing diabetes or gestational diabetes, chronic hypertension or kidney disease, use of assisted reproductive technology ART, and inadequate antenatal care. So, idiopathogenesis. So, here the idiopathogenesis is the abnormal placentation, that is incomplete trophoblastic invasion of the maternal spiral arteries, leads to shallow placentation and reduced uteroplacental perfusion. The hypoxic placenta releases anti-angiogenetic factors like SFLT1, endoglin. Imbalance between vasoconstrictors and vasodilators, that is decrease in NO and increase in endothelin, causes systemic vasoconstriction. This systemic vasoconstriction which causes elevated BP, but unlike preeclampsia, proteinuria and multi-organ injury are absent. So the maternal immunological factors like immune tolerance to fetal antigens may contribute to abnormal placental signaling. So genetic and environment factors are also there, like obesity, diabetes, multiple gestation, maternal age influence the vascular response system and placental development. So that is abnormal placentation which leads to endothelial dysfunction which causes vasospasm, and increase in vascular resistance which leads to elevated blood pressure. So here the idiopathogenesis may cause, because of the imbalance between the angiogenetic factors, they may be raising the blood pressure, that is mild, that could be mild and severe, or capillary leak can cause proteinuria, facial edema, pulmonary edema, pleural effusion, and ascites. And the hematological changes may cause low platelets, AIC, and renal failure. So next comes screening. So why screening is done? So screening is done for the early prediction and early detection of hypertensive disorders of pregnancy, timely monitoring and intervention, and improved outcome for both mother and fetus. will or won't develop the condition. Despite technological advances, early onset preeclampsia, that is less than 34 weeks, still causes high maternal and neonatal morbidity and mortality and increased risk of preterm birth and complications. So, the preventive interventions, the strategies which can be applied if the early detection is done is low dose aspirin prophylaxis can be done, calcium supplementation particularly in the population with low dietary calcium, and nutritional optimization and weight management can be done, and control of anemia, hyperglycemia, and encouraging adequate antenatal care. So the markers for the screening are, it is divided into, biochemical screening markers, biophysical screening markers. So biochemical screening markers are angiogenic and anti-angiogenic markers, that is placental growth factor, soluble FMS like tyrosine kinase, that is SFLT1 marker, and inflammatory and metabolic markers like glycosylated fibronectin, pregnancy associated plasma protein 13, and homocysteine, uric acid, calcium, leptin, and albumin levels. The biophysical markers are the uterine artery Doppler and mean arterial pressure. So, the gestosis refers to a spectrum of hypertensive disorders that occur in the pregnant woman, typically first detected by rise in the blood pressure. So, the conditions that are included in gestosis are pre-pregnancy hypertension or chronic hypertension, gestational hypertension, or proteinuric hypertension, that is preeclampsia. It may also include a typical hypertension presentation without classical signs. So, optimal approach in using the screening tools are to stratify risk early in pregnancy using clinical, biochemical, and biophysical parameters. The first step is to identify the risk based on the clinical history. If the score is high, that is according to the gestosis score, the second step is to apply the biomarkers, that is placental growth factor, SFLT1, glycosylated PAP, etc. Use of uterine artery Doppler to evaluate the placental perfusion. So this helps to select women who could benefit from preventive interventions, especially the low dose aspirin. Aim is to prevent early onset preeclampsia and related complications. So the gestosis scoring, here it is classified into low risk factors, moderate risk factors, and high risk factors. Where the low risk factors, the each is given 1, and the moderate is 2, and the high risk factors are given 3 points. And it is a clinical scoring system, and it is predictive utility mostly in the Indian populations. And the score, if it is 0 to 2, it is considered as low risk, and routine antenatal care is done. And 3 to 5 is moderate risk. Close monitoring, start aspirin prophylaxis. If it is more than 6, high risk, then intensive surveillance, aspirin, and early referral if needed. So the first trimester screening tools are mean arterial pressure, which predicts the preeclampsia. That is, if mean arterial pressure is more than 85 mm in first trimester, it increases the risk. The uterine artery Doppler assess uteroplacental blood flow. High resistance or notching suggests increased risk. And biochemical markers like PAP, low levels is associated with preeclampsia, done in first trimester screening. So the biomarkers that are under evaluation is placental growth factor, SFLT1, TLGF ratio, endobolin, HIF1 alpha, and PP13. These are under evaluation. So the next is the AI-based prediction tools combining the EHR data, biophysical and biochemical markers, patient demography, still under validation but promising for the future screening. So the combined screening algorithms are used, that integrates the maternal history, the mean arterial pressure, and uterine artery Doppler plus biochemical markers. The predictive accuracy of this detection of early onset PE up to 76% and false positive at 10%. So in the combined risk assessment models, we have this fetal medicine foundation algorithm where we take in diabetes, SLE, and with the biophysical markers where the mean arterial pressure, uterine artery Doppler pulse is taken, and biochemical markers like placental growth factor or PAPA, and the risk calculation is done by the Bayesian algorithm, combines all factors to estimate the individual risk of early preeclampsia. If high risk is considered if it is more than 1, and start aspirin 150 mg before 16 weeks, and low risk if it is less than 1. This reduces the early onset of preeclampsia by 62%. The investigations, the maternal blood tests to be done are CBC for looking for the anemia, thrombocytopenia, low platelets in count in preeclampsia and health, liver function test, renal function test for urea, creatinine, serum uric acid, lactate dehydrogenase, coagulation profile, that is PT, APTT, INR and fibrinogen, and peripheral smear should be done. So the urine test to be done are the urine protein creatinine ratio, preferred over 24-hour urine protein if more than 0.3 is significant, and 24-hour urine protein significant if more than 300, and dipstick urine screening if more than 1 suggestive of proteinuria. So fetal surveillance can be done with ultrasound, that is growth scan, to assess the fetal growth restriction. Amniotic fluid intakes, low levels may indicate placental insufficiency. Doppler studies check for abnormal placental perfusion. Non-stress test monitor fetal heart pattern and variability, and biophysical profile composite score for fetal well-being. So the prevention of preeclampsia. Between 12 to 13 weeks, continue till 36 to 37 weeks. Calcium supplementation, that is low dietary calcium intake, less than 600 mg per day. If the dose and timing is 1.5 to 2 grams per day. Lifestyle modification like to be done in obesity and sedentary lifestyle. Exercise control of weight control. No role of vitamin C, E, fish oil, and low molecular weight heparin. So the take-home message is that HTB is a leading cause of maternal and fetal complication, but it is predictable and preventable. Gestosis reflects the full spectrum of hypertensive disorders, not just classic preeclampsia. No single test suffices. We need a multi-parametric approach. The first trimester combined screening significantly improves the early detection. The gestosis for more than 3 should prompt initiation of low-dose aspirin. Emerging tools like AI and FMF algorithms show promise for precision screening. Preventive care is key, especially in resource-limited setting like ours. Every antenatal visit is an opportunity to screen, educate, and intervene. Empower your healthcare teams to recognize the early signs, even the subclinics. And finally, remember, timing is everything in hypertensive disorders of pregnancy. So I would like Dr. Meenakshi ma'am to continue with the management of hypertensive disorders in pregnancy.
Hello everyone. Today I will be dealing with the diagnosis and management of the hypertensive disorders in pregnancy spectrum. So thank you Raga for that nice introduction about screening. So just a small note, there is no tentative or definitive screening test available for placental or for hypertensive diseases in pregnancy, but the evolving tests which are coming up are the PLGF and also the FMF algorithm, where we have noted that the detection of early onset preeclampsia can be detected with a high positive predictive rate, but more studies are required so that we can incorporate it. It has been seen in the NICE guidelines that the effectivity is very good, but due to cost-benefit analysis, they have not been able to put it into their routine practice. We in India, since we don't have a medical system in terms of insurance, we may be able to perhaps sit in our clinics, look at a gestosis score, triage patients over there into which are high risk, which are low risk, and among the high risk patients, we can probably offer them that this is one thing that may help you detect preeclampsia earlier, and we may be able to take better precautions. So considering that, that may be one possibility. The second possibility is also the glycosylated fibronectin, which many studies have been done, but there's no conclusive evidence as of now. We do have the test in our hospital. It's also known as the Lumella test, wherein you test it and it basically talks about vascular remodeling, because fibronectin is important in vascular remodeling, and since the basis of preeclampsia is vascular remodeling deficiency or inadequacy, this is a promising marker that probably needs more studies to come into the system. So I will be dealing with the management of all the spectrum covered. One is chronic hypertension. So ideally chronic hypertension should be coming for preconceptional counseling, wherein we would like to optimize the BP before conception with a target BP of less than 140/90. Stop teratogenic antihypertensives, mainly the ACE inhibitors, the ARBs, the thiazide or the thiazide-like diuretics. Start pregnancy-safe medications if needed. Evaluate for end organ damage, mainly renal, retinal and cardiac, by getting a baseline evaluation so that you know your pre-pregnancy evaluation has a baseline. Folic acid supplementation as usual. When we come to antenatal assessment, BP monitoring should be done at every antenatal visit. Home BP monitoring is an option now that we can tell patients who are educated. The target BP is between 120 to 160 by 80 to 105, whereas while on medication, we're looking at a target BP of 130 by 85. Antihypertensives, the first line preferred are levodopa, second would be nifedipine. Methyl-dopa is being used but much less in India. So low dose aspirin, if it has been started, it's ideal, and it also comes in the Gestosis score of 3. So therefore, whenever you see a chronic hypertensive, it would be advisable to start low dose aspirin. Calcium supplementation in case dietary calcium is low. Antenatal assessment, the monitoring would be the labs which are CVP, LFT, RFT every 4 to 6 weeks or based on the clinical situation. So urine protein creatinine ratio as a baseline, and then as and when we see that there are certain progression is not as per anticipated, we may repeat it. Ultrasound growth and Doppler from 28 weeks onwards. Always watch out for a preeclampsia surveillance, because chronic hypertensives are at a higher risk of progressing to preeclampsia. So watch for sudden rise in BP, proteinuria, edema, visual or cerebral disturbances. Keep this in mind while you're writing your antenatal record. Make a point that she is a chronic hypertensive and these need to be done based on the clinical situation. So timing of delivery would be, in case well controlled, no complications, we would like to terminate by 38 to 39 weeks, not prolonging more than that. If there's a superimposed preeclampsia or a fetal compromise, individualized, may definitely require earlier delivery. If it's uncontrolled hypertension or end organ damage detected, then consider delivery after 37 weeks or earlier based on maternal or fetal compromise. Postpartum care, continue antihypertensives, monitor BP every 4 to 6 hours while in hospital. Beware of postpartum hypertension rise, especially day 3 to day 5. That's an important time where we need to rescreen them or call them back for a BP check. Restart or continue long-term antihypertensives postnatally. The breastfeeding safe medications would be labetalol, nifedipine. Currently, even enalapril can be started based on consultation with a physician. Methyl-dopa is to be avoided in the postpartum period, considering that postpartum depression is increased. Review at 2 weeks and definitely at 6 weeks for further follow-up with review with a physician, because these are people who might continue as chronic hypertension. Those managements and antihypertensive managements need to be considered. So when we now move on to chronic hypertension with superimposed preeclampsia, this can occur in 17 to 25% of pregnancies with chronic hypertension. So here it's a new onset proteinuria or features of preeclampsia after 20 weeks of gestation. So up to 20 weeks the hypertension is high, but new onset features start after 20 weeks. The management here will require close fetal maternal monitoring and timely delivery. So the diagnosis would be new onset proteinuria would be a spot protein creatinine ratio more than 0.3. Currently 24-hour protein monitoring is not advised. New end organ dysfunction can be judged by a thrombocytopenia, elevated liver enzymes, renal insufficiency, a creatinine more than 1.1 or a doubling, pulmonary edema, cerebral or visual disturbances. So whenever we are evaluating and you want to know worsening, you want to have a baseline. So always get a CBP, LFT, RFT and maybe a spot protein creatinine ratio at baseline for ANC, including a serum creatinine, so that you know what baseline you're working on and where it is actually worsening. So inpatient versus outpatient, if the patient is stable, BP control, no end organ dysfunction or no organ dysfunction, we can manage as an outpatient with frequent follow-up. But in case the patient is unstable, where there is severe hypertension or signs of maternal or fetal compromise, admit for close monitoring and management. So medical management would come under these 4 categories. One would be the target BP. In case of a severe hypertension, we would want to reduce the BP less than 160 by 110. While on medication, we would look at a target BP of 130 by 85. Antihypertensives, labetalol IV or oral depending upon the situation. Nifedipine is also preferred. Magnesium sulfate for seizure prophylaxis, or if there are severe features or there is eclampsia. Low dose aspirin, do continue if it's already been started before. Steroids, in case they're less than 34 weeks and delivery is anticipated within 7 days, it is given for lung maturity. So maternal monitoring here would be BP every 4 to 6 hours, a daily urine spot PC ratio, blood tests like the labs every 2 to 3 days because it's a superimposed preeclampsia. Watch for again signs of impending eclampsia like a headache, visual symptoms, right upper quadrant pain or a decreased urine output. Fetal monitoring would be the daily fetal kick count, twice weekly NST, bi-weekly growth scan, Doppler and AFI. So timing of delivery, in case they are stable with no severe features, 37 weeks is our cutoff. With severe features, more than 34 weeks or earlier if maternal fetal condition deteriorates. Unstable or eclampsia, it is immediate delivery regardless of the period of gestation, but it would be after stabilization of the mother. Postpartum care, continue antihypertensives, here dose adjustments will be required. Monitor BP spike again up to 6 weeks postpartum because these are the people who may progress into a worsening in the postpartum period. So keeping them in our radar, marking it as a red and informing the patient that a follow-up is required. Magnesium sulfate for 24 hours postpartum if given intrapartum, evaluate for long-term cardiovascular risk. Now moving on to gestational hypertension. The classification as per the ACOG is mild and severe. So in mild it's between 140 to 159 by 90 to 110 and severe is more than 160 by 110. So here general principles would be monitor for progression to preeclampsia because this can happen, frequent maternal and fetal surveillance, delivery timing based on BP control and gestational age. So in case the setting would be OPD is generally sufficient for a mild gestational hypertension, maternal monitoring with BP twice weekly or even a weekly ANC, weekly labs, urine protein once you've done it, that is sufficient. Later on, in case you're finding any worsening symptoms, then you can repeat. In fetal monitoring, fetal growth scan every 2 to 3 weeks and a weekly NST. Antihypertensives, though they say are usually not required more than 150 by 100, I think all of us in clinical practice do start antihypertensives beyond 140 by 90. Delivery again is 37 to 39 weeks if stable. We are not letting the gestational hypertension progress beyond 38 weeks because beyond that we know that the progression or maternal and fetal outcomes can be jeopardized. In severe gestational hypertension, here we are talking about only a BP rise but no other end organ damage. That's why it still remains as a gestational hypertension. There is no proteinuria or no target organ damage. But this needs to be differentiated from preeclampsia, which can become a clinical difficulty. So here maternal monitoring, once the BP is very high, you would want to work on every 15 minutes BP check until the BP is less than 160 by 100 and then every 4 to 6 hourly. Definitely the labs and the urine protein every 2 to 3 days because you're worried that this may progress to a preeclampsia. Fetal monitoring, daily NST, AFI, growth scans every 2 weeks. Antihypertensives depending upon the urgency would be either an oral labetalol or an IV, nifedipine or a hydralazine if a rapid BP control is required. Magnesium sulfate generally not required unless there is signs of severe preeclampsia or seizure. Delivery beyond 37 weeks if BP controlled, but if uncontrolled or signs of preeclampsia, consider delivery after 34 weeks. Postpartum, again here monitor BP daily for up to 72 hours and then 3 to 5 days up to 6 weeks. Antihypertensives may be required postpartum. Counsel about the risk of chronic hypertension and recurrence in future pregnancies. Moving on to preeclampsia, so we have preeclampsia without severe features and preeclampsia with severe features. So in preeclampsia without severe features, it's a BP of 140/90 with mild proteinuria or minimal lab abnormalities. Whereas in a severe preeclampsia, it is more than 160/110 with end-organ dysfunction, which may be a thrombocytopenia less than 1 lakh, elevated LFTs, renal impairment, cerebral or visual symptoms, or a pulmonary edema. So general management principles is without severe features, we can go in for outpatient or inpatient. Usually BP control is required if BP is more than 150/100. Seizure prophylaxis is not required. Fetal surveillance would be a weekly NST growth scan every 2 to 3 weeks and labs done every 1 to 2 weeks. Delivery timing would be 37 weeks where it is preeclampsia without severe features. If it is with severe features, it is an inpatient management. Target BP is 140 to 150/90 to 100 with either labetalol or nifedipine. Magnesium sulfate generally will be required as seizure prophylaxis, daily NST, biweekly Doppler BPP, CBC and labs every 2 to 3 days, and you're looking at a cutoff of 34 weeks. Once the baby or the gestation is at 34 weeks, we would prefer termination unless further instability pushes us to deliver before or prior treatment with corticosteroids. So acute management of severe preeclampsia is magnesium sulfate, antihypertensives, fluid restriction and monitor input-output. So indications for immediate delivery any period of gestation would be eclampsia, uncontrolled severe hypertension, pulmonary edema, DIC, HELP, fetal distress or intrauterine fetal demise. Postpartum care again here would be to continue antihypertensives, continue magnesium sulfate to 24 hours after delivery, monitor BP closely up to 6 weeks, counsel regarding the cardiovascular risk and recurrence in future pregnancies. Moving on to eclampsia, we all know this is generalized tonic-clonic seizures in a lady without ruling out other neurological abnormalities. So it is a life-threatening obstetric emergency requiring immediate multidisciplinary care. There are 4 basic principles of eclampsia management. One is stabilize the mother, control seizures, control BP, plan timely delivery after stabilization. So the emergency management can be noted as the ABCDE approach: airway, breathing, circulation, disability to assess consciousness and monitor reflexes, exposure mainly monitor vitals, catheterize to monitor the urine output. So as we know, there are 2 common regimens, it's the Pritchard and the Zuspan. Generally the Zuspan is followed here, whereas in a tertiary referral center to give the loading dose and then in utero transfer to a higher center, Pritchard may be preferred. In our center, we are following the Zuspan regimen. So monitoring parameters, we know they are the DTR, the urine output, the respiratory rate. So normally a serum magnesium level is not indicated. But when will you start maybe thinking of a toxicity? One is when the DTRs are absent, they are the first to go because it implies that the magnesium level is more than 7. So normal range is 4 to 7 milliequivalents. Beyond 7, there's loss of DTRs. Beyond 10, there's respiratory paralysis. Beyond 25, there's a cardiac arrest. And how do we handle this? Is with an antidote of 10% calcium gluconate over 10 minutes. So fetal assessment here would be fetal monitoring by either an NST or a fetal Doppler, and delivery decision would be based on maternal stabilization. So timing of delivery, it is indicated after maternal stabilization. Vaginal delivery preferred if possible, and if induction of labor can be done safely. NSCS if obstetric indications or fetal maternal compromise, continue MAXAL for 24 hours post-delivery or the last seizure. Postpartum, of course, it would be the routine, monitor BP, urine output signs, continue antihypertensives, counsel on the recurrence, and long-term cardiovascular health. So just a note on the management for antihypertensives for urgent BP control in pregnancy, we have the IV labetalol, amlazine, or the nifedipine. The labetalol is generally preferred because of lesser side effects and tachycardia is less. Nifedipine is the oral regimen. Just a note on the HELP syndrome. So in HELP, we know it's hemolysis, elevated liver enzymes and low platelet counts. Incidence is between 0.5 to 0.9, seen in 10 to 20% of severe preeclampsia. Typically occurs 27 to 37 weeks but may present postpartum. This needs to be kept in mind. Any of the preeclampsia that we see that has not been addressed properly can present the postpartum period as a HELP. So again, here there are 2 classifications, the Tennessee and the Mississippi. I think we're all aware of this. Clinical features are very similar to a severe preeclampsia. The investigations are similar, except that we would also be going in for a coagulation profile because we are suspecting that it may progress to a DIC. So health management, again for 3 principles: stabilize the mother, evaluate for delivery, blood products. Postpartum monitoring, BP, renal function, platelets, LFT. Resolution generally occurs 48 to 72 hours post-delivery, so that's a little reassuring. The complications though are DIC, acute renal failure, liver hematoma rupture, pulmonary edema, a maternal mortality of 1 to 3%, fetal complications like an FGR abruption, prematurity or a stillbirth. So just a note on recurrence. So we've seen a case of hypertension in pregnancy. What are the chances of recurrence? So one is any hypertension in pregnancy, it can result in 21% recurrence of any hypertension in pregnancy in future. It can result in a 20% preeclampsia, 20% gestational hypertension. A preeclampsia can result in a 14% any hypertension in pregnancy. Preeclampsia, presenting again as a preeclampsia, can be 16%, but it doubles if there has been a 28 to 34 week birth in the previous pregnancy, and it becomes 23% if it's between 34 to 37. Gestational hypertension is 9% up to 12 and up to 15. Chronic hypertension can progress in 2% and 3% to gestational hypertension. Just a small note on the press. So this is something that can be very confusing in the postpartum period. So it's a neurotoxic state characterized by subcortical vasogenic edema, primarily affecting the posterior parieto-occipital lobes, but it's usually reversible with appropriate management. Now the etiology, there are 3 or 4 main reasons. It can be a hypertensive encephalopathy, it can be a preeclampsia, eclampsia, autoimmune diseases, immunosuppressants, chemotherapy, or sepsis or severe infection. So the clinical features are very similar to an eclampsia, wherein we have headaches, seizures, visual disturbances, nausea, vomiting, or some very less common focal neurological deficits. The diagnosis here would be an MRI, which will show bilateral symmetric vasogenic edema in the parieto-occipital lobes. So workup would be BP monitoring and RFE, electrolytes, CBC, LFT, and an autoimmune or infection screen only if indicated in the etiology. So press management, again, control BP. The only difference here is there should be a gradual reduction in BP using IV antihypertensives because avoid rapid overcorrection to prevent an ischemia. So seizure management can either be benzodiazepines for acute seizures, anti-epileptics, or it will be magnesium sulfate if the etiology was preeclampsia, eclampsia. Remove or seize the offending agent if the cause was that. Supportive care. So in summary, hypertensive disorders in pregnancy contribute significantly to maternal morbidity and mortality. A good clinical history, because we see that the recurrence of preeclampsia is there. Using appropriate screening tools in high-risk patients can help identify those at future risk. Frequent follow-up in the high-risk patients, a timely referral to higher centers, having a multidisciplinary team, including an obstetrician, physician, critical care, neonatology, can alter outcomes to a great extent. But finally, for us obstetricians, balancing maternal morbidity versus fetal maturity is always a dilemma in treating hypertensive disorders, and it's only the clinical course which will direct us towards the respective action. So I thank you all for a patient hearing. Thank you.
It was a nice and clear presentation, ma'am. You have covered almost everything, including the emergencies and from the OPD management. And I would like to keep a note on this regarding the importance of screening and the role of, as ma'am was already explaining, multidisciplinary team, including the physicians, anesthesiologist, and pediatric team also. And I also emphasize on the role of family for monitoring the women who has been having this risk factor while she is pregnant, and postpartum and later life tendency or risk to develop hypertension as they age. So I think we have to emphasize that point, and the individualized screening of the women she is at risk for development of essential hypertension as she ages also.
I think very rightly said, ma'am. Just like GDM, we say the increased chances of developing diabetes in the next 5 years, the risk is a little higher. So we do ask for an annual HbA1c and a fasting postprandial. Similarly, in hypertensive disorders in pregnancy, we should be asking for, maybe Vaswani ma'am would be able to tell us a note on how to screen, maybe annually, what would be important for women who have had hypertensive disorders in pregnancy.
Comprehensive talk, ma'am. So talking about the cardiovascular risk, so once a high-risk pregnancy female delivers, the role of the obstetrician does not end there. Beyond that, now the patient will first come to you for guidance counseling. So the first thing is you counsel them that this patient is at very high risk of developing hypertension in the future, whatever may be the spectrum of the hypertensive disorder during pregnancy. Though preeclampsia has a much higher risk than the other forms, but here, once it is done, counsel the patient that they have to go for regular BP checks for at least first 12 weeks, and after that at 1 year, and after that every year one comprehensive cardiovascular workup should be done, because as per the available literature, in the first decade post-pregnancy, they are at higher risk of developing hypertension, and along with that higher CV risk. So when we talk about CV risk, sometimes we just assume that we are talking about coronary artery disease. No, that is not the thing. Hypertensive disorders of pregnancy, what they actually cause is they increase the LV mass. So here there is one understated statement, that is diastolic dysfunction. These patients, they come with SOPs, that is not because of the coronary disease, that is mainly because of the heart failure with diastolic dysfunction, preserved ejection fraction heart failures. So a thorough 2D echo checkups are needed, and these days we have very well evaluated markers on 2D echo itself, where we can identify the patients with diastolic dysfunctions and treat them accordingly, because we have few medications that are really helping the patients and improving the quality of life. And one more thing is, when it comes to workup, these patients, they should further be worked up with HbA1c's, routine NT-proBNP checkups, because they are silent markers that the patient is developing hypertensive heart diseases as well.
Thank you, ma'am. Thank you, everyone.
We sincerely thank Dr. Raga Reddy and Dr. Meenakshi for the valuable presentation on the hypertensive disorders in pregnancy, offering both clinical insights and practical management tips. I want to express my gratitude to Dr. Daya, Dr. A. Shilpa and Dr. Shravani Reddy for guiding this session expertly and encouraging meaningful discussion. I now request Mr. Suvankar, Center Head of Medicover Oncology Institute, please come on the dais and present the mementos to our moderators, Dr. Daya, Dr. Shilpa and Dr. Shravani.
That's the thing. I'm looking.
I now request sir to please present the mementos to our speakers, Dr. Meenakshi and Dr. Raga Reddy. Our next session focuses on a growing area of concern in obstetric care, metabolic disorders in pregnancy, including gestational diabetes, thyroid dysfunction and obesity. These conditions are increasingly prevalent in modern obstetric practice and have far-reaching implications on both maternal and fetal health, influencing outcomes during pregnancy, after delivery and beyond. We are privileged to have us with us Dr. Shravani Reddy Karamuru, consultant physician at Medicover Women and Child, who brings a rich blend of internal medicine expertise and experience in collaborative obstetric care. Dr. Shravani will guide us through the pathophysiology, screening protocols, multidisciplinary management, and the practical approaches to metabolic disorders during pregnancy. And moderating this session, Dr. Surendra Prasad sir, a consultant endocrinologist, Medicover Hospital, who will be leading the discussion and facilitating a meaningful dialogue to bridge the medical and obstetric perspectives in managing these conditions. I welcome Dr. Shravani ma'am and Dr. Surendra Prasad sir to come onto the dais and begin this session.
Good afternoon everyone. Myself Dr. Shravani Reddy Karamuru, consultant physician, Women Health and Geriatrics, Medicover Hospitals. I would like to give a brief presentation on metabolic disorders in pregnancy, like obesity, diabetes and thyroid disorders. The overview of metabolic disorders in pregnancy, what we cover today is definitions, rising global prevalence, interrelation of these conditions and impact on maternal and fetal outcomes. Objectives of the presentation: understand the pathophysiology changes, physiological changes during pregnancy, discuss the outcomes and complications, review current evidence-based practices and guidelines and management strategies. Coming to obesity, obesity is a rising health concern both in developing and developed countries. WHO has declared obesity as a global epidemic. As such, obesity is a chronic imbalance between intake and expenditure of calories, resulting in the accumulation of the adipose tissue, adiposity. And adipose tissue is an active endocrine organ. When in excess, can dysregulate the metabolic and inflammatory pathways, resulting in metabolic disturbances. And the definition of obesity, WHO definition of a BMI of more than or equal to 30 kg/m² is grade 1, considered as grade 1 obesity, 30 to 34.9 as grade 2, and 35 to 40 is as grade 2, and more than 40 as grade 3 obesity. In Asian populations and among Indians, we consider the high as 23, more than 23.5 as above normal, overweight, and more than 27.5 kg/m² as high risk for our populations. Nowadays, the prevalence of obesity has been increasing among reproductive age group women, raising the concerns of subfertility and high risk during pregnancy when the woman becomes pregnant. The maternal risk involved when a woman with obesity is pregnant is other metabolic disorders like gestational diabetes, hypertension, thromboembolism, and poor labor progression or induction, cesarean deliveries, thromboembolism, and recovery like wound infections, postpartum hemorrhage, postpartum depression, like that. And fetal and neonatal risk in a woman with obesity, in a pregnant woman with obesity,
birth defects, miscarriages, early miscarriages or stillbirths, and fetal macrosomias, dystocias, shoulder injuries while delivering, and other childhood obesity and metabolic disorders, hypoglycemia, neonatal meconium aspirations, and birth injuries. So, ideally, the management of women with obesity comes from preconception. The ideal point of correction or management starts in preconception. When a woman with obesity desires to become pregnant visits the clinic, the women should undergo thorough endocrine, cardiac and pulmonary evaluation and should be counseled regarding the risk involved when she becomes pregnant, and she should be emphasized the importance of weight loss, considering at least 5 to 10% of current weight loss will have a beneficial effect on her pregnancy and pregnancy outcomes. And for that, the management comes from basic lifestyle modifications through diet, exercise, and when involved or when the response is inadequate, through pharmacotherapy and surgical methodologies. The diet includes a balanced diet of whole grains, seasonal vegetables and fruits, cutting down the processed foods, fat dairies, and excess food intake as per the cravings. And exercise, the women should start exercising gradually with a goal of being active at least 30 minutes in a day as an exercising thing like walking, swimming and outdoor sport. And if the above lifestyle changes were still not meeting the target goal of at least 5% to 10% loss of the current presentation weight, the patient should be advised to start on pharmacotherapy, anti-obesity medications like we have limited anti-obesity medications like Orlistat, phentermine, topiramate combinations, and the newer generation GLP and GIP agonist, receptor agonists. On that note, I would like to stress that few anti-obesity medications will have teratogenic effects. So, a strict contraceptive methodology should be in place while the patient is on such kind of drugs like phentermine and topiramate. And I would like to be in brief on GLP and GIP agonists here. These are the newer generation drugs that have been in place for diabetes management, which also have a role to play in chronic weight management. Tirzepatide, which has been recently approved in our country, dual GLP, glucagon-like peptide and glucogenic insulin polypeptide 1 receptor agonist, is a newer approval in our country, which can be used for the weight management, chronic weight management. And the mechanism of action of tirzepatide is, it acts mainly through GLP and GIP in the gut, giving delayed gastric emptying, early satiety, though decreasing the cravings, and through liver and pancreas by reducing the hepatoglucogenesis. And the dosage of this medication is to start with 2.5 milligrams subcutaneously every week for 4 weeks and can be up-titrated at a rate of 2.5 milligrams every week for every 4 weeks until the desired effect is acquired. The side effects of the most common side effects of tirzepatide are GI, because the site of action including nausea, vomiting, diarrhea and bloating sensation are the most common reported side effects for this drug, and it can also have severe diarrhea and cholestasis and cholelithiasis. So, before initiation of tirzepatide for the chronic weight management, the patient should have thorough evaluation of LFTs, gallbladder and gut who have delayed gastroparesis, like delayed gastric emptying issues should be contraindicated. And with chronic gastritis and all, caution should be taken care of, and avoidance or treatment of these side effects is through hydration, small frequent meals and small sized portion meals. The drug is contraindicated in pregnancy, breastfeeding and thyroid carcinomas and pancreatitis and gallbladder issues. So patients with already known existing these issues are contraindicated to initiate Pixipatine. And guidelines from different obstetric societies regarding the management of obesity and WHO based on the BMI definition, as I told, obesity is a spectrum of management, team management, preconception counseling, as we was discussing till now, and folic acid supplementation initiation, followed by antenatal care. The first visit, when a woman with obesity is pregnant and visits the clinic for the first time, she should undergo her basic evaluation profile on diabetes, pregnancy-associated hypertension, thyroid dysfunctions, urine proteins, and sleep apnea, and other issues. And a proposed weight gain for a woman with obesity who is in pregnancy is, for a BMI less than up to 30 to 35, they can gain around 7 to 9 kgs, and for a BMI more than 35, 5 to 7 kgs throughout the pregnancy, based on individual response and individual targets. And here, if required, nutritionists should be involved to make sure that nutritional deficiency and small for gestational age fetuses are not, we are not seeing any deficit on that. And in intrapartum, intrapartum also poses challenges in women with pregnancy women, where they have anesthesia considerations, prolonged labor or failure of induction, and prolonged delivery and assisted delivery or taking for cesarean sections, where the intubation or other causes might be different and difficult. So later, after postpartum, the women may have thromboembolism. So thromboembolism prophylaxis should be given when and where required, and IV prophylaxis of antibiotics should be given to prevent infections. Immediate postpartum, as we discussed, increased risk of postpartum pregnancy, postpartum hemorrhage will be there, venous thromboembolism prophylaxis, and there will be delayed initiation of breast milk production in obese women, where they should be counseled for more than 72 hours. They should be counseled and reassured on that, and they should be encouraged to give to continue breastfeeding, which will also aid in the weight loss and weight management. And they can be taken, should be counseled and should be taken care of postpartum weight retention and weight management issues, postpartum depression issues, and other existing medical or metabolic illnesses if they have encountered while they are pregnant. Coming to diabetes in pregnancy, pre-gestational diabetes, type 1 diabetes and type 2 diabetes, gestational diabetes, any degree of glucose intolerance with onset or first recognition during pregnancy is gestational diabetes. Pathophysiology of gestational diabetes in early pregnancy, we have increased insulin sensitivity, increased maternal fat storage. The gestational diabetes is when most of the times we see in late trimesters in view of increased insulin resistance, for which the woman is unable to meet the demands of insulin production. So where the resistance has been increased and the desired target of insulin production was delayed, where we see dysglycemia or hyperglycemia, where we pronounce it as gestational diabetes. So in late pregnancies, increased insulin resistance and pregnancy hormone mediators will propagate the insulin resistance. If the insulin demand production has not met the increased resistance, we will see hyperglycemia. Diagnosis of gestational diabetes, oral glucose tolerance test, giving a 75 grams of glucose, which has to be screened at around 24 to 28 weeks of gestation and at first antenatal visit if in high risk women. The thresholds of the test are fasting more than 92, 1 hour more than 80, and 2 hours more than 153 milligrams per deciliter. Any one abnormal value will confirm the diagnosis of gestational diabetes. It's a nice flowchart representing the maternal complications in diabetes. Obstetric complications like preeclampsia, preterm labor, miscarriage, polyhydramnios, and delivery complications like going to cesarean section or birth trauma to the neonate. Metabolic complications, the women may have hypo and hyperglycemic episodes, diabetic ketoacidosis, infectious complications of frequent UTI, urinary tract infections and candidiasis, long-term risk, progression to end organ issues because of hyperglycemic state like diabetic retinopathy, diabetic nephropathy and increased cardiovascular women risk compared to women with no diabetes, and risk of type 2 diabetes later in life. Fetal and neonatal complications in women with diabetes. Fetal complications, congenital anomalies like neural tube defects, cardiac defects, intrauterine growth abnormalities like macrosomia, intrauterine growth restriction, and intrauterine fetal demise. Neonatal complications, metabolic issues in the newborn like hypoglycemia, hypocalcemia, hyperbilirubinemia can be seen, and respiratory distress syndrome, polycythemia, and cardiomyopathy. Long-term risk to the baby who has born to a mother of gestational diabetes would be obesity, type 2 diabetes and neurodevelopmental delays, which should be emphasized to the family. Management of gestational diabetes, ADA Guidelines 2024. Universal screening, one-step approach, two-step approach. Two-step approach is one they practice in US and Canada, where we practice only one-step approach of 75 grams glucose. And lifestyle modification and lifestyle changes are a continuous spectrum with any form of support to the diabetes. Nutrition, weight management and glucose monitoring. Glycemic targets are fasting less than 95, first hour less than 140 and second hour less than 120. Coming to the pharmacological therapy, though metformin and glyburide can be given to pregnant women, the first choice of drug for the women with diabetes in pregnancy is always insulin, making a combination of ultra-short acting and intermediate acting insulin individually based on the patient glycemic targets and glucose hyperglycemic disturbances is advised. And in type 1 and type 2 diabetes, women with pre-existing diabetes who become pregnant, they should be emphasized to be with a prenatal, pre-conception targets of HbA1c and well-maintained euglycemia before they plan for pregnancy. And if they are planning for the pregnancy and they are on oral hypoglycemic agents which were not advised while pregnant, the drugs can be switched over to the insulin or metformin or other supportive drugs that can be given during pregnancy. When diabetes complicating pregnancy, management occurs pre-conception as with an optimization of HbA1c, folic acid supplementation and medication adjustment by switching over to insulin and monitoring of frequent blood glucose checks, ultrasound for fetal growth, HbA1c every trimester. Trimester specific management, in first trimester avoiding the hypoglycemia risk and insulin dose adjustments as most of the organ formation happens. Second trimester, screen for complications, adjust insulin regimen. Third trimester, monitor fetal growth and increased insulin needs as the insulin resistance peaks during the late trimester. And delivery planning, aim for 38 to 39 weeks of period of gestation if the patient is otherwise stable and a multidisciplinary team involvement. Postpartum, reducing the insulin dose immediately and monitor for maternal hypoglycemia, encouraging the breastfeeding, follow-up glucose and HbA1c testing after 1 week. Thyroid disorders in pregnancy, an overview. Thyroid disorders like thyroid, anatomically, thyroid gland undergoes in pregnancy thyroid gland undergoes both anatomical and physiological changes. Based on the population and location and region, anatomically the thyroid gland may increase from up to 10 to 30% of its size anatomically, and physiologically the thyroid binding globulin levels were increased from the liver, which result in increased levels of total T3 and total T4. Therefore, always the thyroid function test should be reviewed in pregnancy women differently, with the kit available with the reference ranges according to the kit. Hypothyroidism in pregnancy. Most common is autoimmune Hashimoto thyroiditis, elevated TSH and low free T4. We always consider looking at free T3 and free T4 in pregnancy for the definitive involvement and titration of the doses than the total T3 and the total T4. Hypothyroidism causing maternal risk like infertility or subfertility, miscarriage or early pregnancy loss, preeclampsia, gestational hypertension, placental abruption, postpartum hemorrhage, anemia, heart failure and postpartum thyroiditis. And the mechanisms involved were those. Fetal risk, preterm birth, low birth weight, fetal demise or stillbirth, neurodevelopmental delay, low IQ or cognitive impairment, which we have been seeing through the public ads also since our childhood. Iodine, emphasizing the role of having iodine in our diet. And congenital hypothyroidism, if maternal antibodies crosses the placenta. Hypothyroidism, the target management, TSH target in pregnancy, first trimester is always less than 2.5. In second and third trimesters, less than 3 million international units per liter, and levothyroxine dose in a woman with pre-existing hypothyroidism also. We advise increasing the dose to 20 to 30% or 2 extra tablets per week to meet the increased demands when she is pregnant. And monitor serum TSH in existing hypothyroidism and gestational hypothyroidism every 4 weeks is advisable. Subclinical hypothyroidism, elevated TSH but normal free T4. Here we have to decide when to start levothyroxine supplementation. Is again, if TPO antibodies are positive and TSH is more than 4 million international units per liter, we emphasize on starting levothyroxine supplementation in such situations. Hypothyroidism in pregnancy, the most common cause of hypothyroidism is Graves' disease, and it is the lab values are suppressed TSH and elevated FT4. Gestational thyrotoxicosis is an entity where the cross-reactivity of beta is seen early in pregnancy and will suppress during 18 to 20 weeks of pregnancy, where we see cross-reactivity of beta HCG involving with the TSH and rising a slight increase in the free T3 and free T4 levels. Again, the treatment is most of the times, it is associated with hyperemesis gravidarum. So, hydration and wait and watch is most of the times will be enough. If required, a low dose antithyroid medications for some time is advised. Hypothyroidism and maternal risk, miscarriage, preeclampsia, heart failure, thyroid storm, placental abruption, preterm labor, osteopenia and exacerbation of Graves' orbitopathy. Fetal risk, fetal growth restriction, preterm birth, fetal tachycardia, fetal goiter, neonatal thyrotoxicosis, low birth weight and stillbirth. Management of hyperthyroidism in pregnancy. Propyltyracil and metimazole are the drugs of choice for the management of hyperthyroidism in pregnancy. Propyltyracil can be given all throughout the pregnancy, but metimazole is teratogenic effect, so we start or initiate or switch over to metimazole from second trimester. And we measure thyroid receptor antibodies at 24 to 28 weeks of gestation in Graves or history of thyroidectomy. Thyroid autoimmunity in euthyroid women. Thyroid peroxide oxidase antibody status is associated with TPO antibody positive status is associated with increased miscarriage, higher incidence of preterm birth. So LT4 therapy may be considered if serum TSH is more than 4 or if it is an assisted reproductive technology. The conception is through ART. So in pregnancy, the metabolic disorders should need an interdisciplinary approach with an endocrinologist, anesthesiologist, obstetrician, nutrition and physician for a personalized care. We should emphasize on early intervention and close monitoring. Summarize, obesity increases maternal and fetal complication. Weight optimization, preconception is the key. Lifestyle modification is the core strategy. Diabetes, gestational diabetes, diagnosis and control reduce adverse outcomes. Insulin is the gold standard of treatment. Continuous glucose monitoring adds benefit, particularly in type 1 diabetes women. And lifelong risk persists postpartum, which should be emphasized to the women for further screenings of or regular periodic screenings for the diabetes. Thyroid dysfunction impacts pregnancy outcomes, screening, levothyroxine and antithyroid drugs as per the guidelines substitution, and monitoring TSH and free T4 levels regularly every month or every 4 weeks is advisable. Recent advances and research highlights of the importance or the intervention of continuous glucose monitoring in type 1 diabetes through concept trial, LT4 in euthyroid or TPO positive ART in women, telemedicine GDM management, concept trial for diabetes, SURMOUNT trial, ongoing trial for the tirzepatide in obesity, chronic weight management, poster study for the evaluation of LT4 in ART treated women. Postpartum and long-term health, breastfeeding benefits, both diabetes, obesity and thyroid, long-term screening for type 2 diabetes and thyroid, weight and lifestyle counseling. Patient education strategies, clear, tailored counseling based on the individual needs and recommendations, culturally sensitive dietary advice, engage the family support. Public health implications of these metabolic disorders is rising. Non-communicable diseases are the rising burden from maternal metabolic risk, maternal metabolic milieu, need for preconception care policies, universal screening in high-risk areas. Key references from ADA standards and Endocrinology Society and RCOG guidelines. Thank you. We stand united, we rise stronger as for the nation, as for our pregnant women also. Thank you.
Good afternoon everyone. I thank Medical Women Shell for giving me this opportunity. And Madam has spoken very nicely and the presentation is very good, concise and comprehensive. Discussed all the key aspects with regard to metabolic disorders, specifically focusing on the diabetes, obesity and thyroid disorders, starting from pre-pregnancy to postpartum. So like if you look into these 3 common metabolic disorders which we daily encounter, we can segregate these 2 into 2 common groups. One is a thyroid disorder and another is a obesity and diabetic group. So looking into the thyroid disorder, mainly definitely when it is the TSH is high, definitely taking an opinion from the specialist has been advised. But when it is in the borderline, definitely some of the few tests like anti-TPO antibody, this will help us in taking the decision and managing by at your level, at gynec level itself, can take the decision of starting the thyroxine. And the most important thing, these are the recent studies have proven that borderline TSH who are having recurrent pregnancy losses, who are with anti-TPO antibody positive, they have shown, studies have shown some benefit on starting the thyroxine medication in them. So one important thing is, it's not looking about the high risk or low risk factors. Every woman who visit in the clinic, they have to be tested for the thyroid. be it pre-pregnancy or pregnancy or post-pregnancy. And coming back to this obesity and the diabetes, definitely these, I personally feel the health of the woman doesn't start pre-pregnancy. It starts right from their infancy and it should continue from then onwards, and we should specifically focus on their early maturity days, and we need to take the proper steps in their nutrition and in their physical activity, and trying to diagnose at early stages at like some of the, because most of the times like PCOD, these things are very common in the society, and these needs to be handled at earlier stages, not at the time of pregnancy or just before the pregnancy. And coming back to the when we look into these 2000s or 2010s, where we as an endocrinologist also we used to focus on the glucocentric approach, but now entire the concept has changed and it is mostly on the weight centric approach. So be it been a PCOD or obesity or diabetes, the primary root is from the obesity. So we need to focus specifically on the weight centric management. Unfortunately, we do not have much FDA approved drugs for it, even though we do have the tirzepatide, but it's too costly and it is it is not that easily available also, and at the same time it is not easily given to the patient because of the financial affordability in our country, especially in resource limited settings. So instead of being on this medication right from the early days, if you just focus on the diet and exercise as a medicine on everyday basis, definitely most of these things can be prevented. Of course, after getting the pregnant, it's been like only advice I give if they have the overweight or the obesity is to maintain the minimal weight gain during the pregnancy, at least 5 to 7 or 5 to 9 kgs. If they are having the obesity like BMI more than 30, more than 35, more than 40 should be up to 5 to 7 is enough, because maternal fat deposits itself is enough for the fetus growth. And coming to the most important thing is the mother health will not stop with the delivery of the baby. Postpartum is very crucial aspect, because they tend to put more weight during the postpartum, and it is a very easiest and toughest also to maintain the weight, and we can able to reduce the weight of the woman if in the proper counseling and proper lifestyle and proper medications. And one more thing I just want to tell is, who are having the specifically like bariatric surgery is one more thing I just want to focus. Bariatric surgery is definitely good enough for the persons, for the subjects who are having the BMI at least more than 35, the 40, we should encourage them definitely going into it. And then it's not very new, coming back to the CGM, it's not very new thing. It has been there since 2000, but it has been more refined. It is more refined. It has come in the form of a very usable tracking at present days. So CGM should be deployed to every pregnant woman if possible, if there is no financial constraints, who are suffering with the diabetes. It costs around 5,000 to 5,500 rupees, and it will stay for 14 days, at least for once in their pregnancy. If we can able to deploy, then definitely it will educate them. Then onwards they can take care with the simple glucometer. Thank you. If any Q&A is there.
Thank you, sir, for briefing into the importance of CGM and the obesity management. As rightly said, weight management is the key for all the metabolic disorders. So everyone should be given a special advice or interest to maintain the weight according to their height and age.
No question and answer, we can wind up, I think.
Thank you.
Thank you.
Thank you, Dr. Shravani ma'am, for your insightful and comprehensive session on metabolic disorders in pregnancy. I also thank Dr. Surendra Prasad sir for skillfully moderating the discussion. Now I welcome Mr. Shrikant, Center Head, Medicover Multi-Speciality Hospital, Madhapur, come on to the dais and kindly present mementos to Dr. Shravani and Dr. Surendra Prasad.
concern in contemporary obstetric practice, placenta accreta spectrum. With a global rise in caesarean deliveries and uterine surgeries, PAS has transitioned from a rare obstetric presentation to a pressing clinical concern. It is our privilege to welcome Dr. Varalakshmi, consultant gynecologist at Medicover Women and Child Hospital, as our speaker for this session. Dr. Varalakshmi brings a wealth of experience in high-risk obstetrics. Chairing and moderating this session, I welcome Dr. Krishna Kumari, Senior Consultant Gynecologist, and Dr. V. Maitri, Consultant Obstetrician and Gynecologist, who will guide the discussion and help us explore the nuances of PS through expert dialogue.
Hello everyone, a very good afternoon to all of you. Today I will be talking about a very important emerging topic. This is a placenta accreta spectrum. This topic gains importance because the number of cases of placenta accreta spectrum are rising nowadays because of the increase in the number of caesarean sections. So we all know after the delivery of the baby, the placenta wonderfully sheds. It comes out like magic. It just comes out of the womb without any difficulty. It gets expelled on its own. And all this 9 months, the placenta is inside the uterus, holding on to the uterus and being a good communication between the mother and the baby, transferring all the important nutrients, oxygen, and carrying the waste from the baby to the mother. So how this wonderfully designed organ, which is staying throughout pregnancy, gets shed immediately after the baby's birth. This is a normal phenomenon, and this is very unique for human beings because this kind of anatomical setup is never there in any other organisms or any other species, and that is why to identify the reasons is very difficult in any other kind of animal models. So, placenta accreta spectrum is a condition wherein the placenta does not get shed immediately. It is a condition where there is adherence of the placenta to the myometrium. It could be a partial adherence, or it could be a completely embedding, or it could be an invading placenta throughout the entire breadth. So, placenta accreta spectrum, which is seen in the recent times, it's been noticed that the incidence of this condition has increased about 10-fold in the last 50 years. And this is one of the most important causes of maternal morbidity and mortality, and a leading cause of peripartum hysterectomy. Thus, we need to understand why this condition is not happening. The normal shedding of placenta is not happening like a normal physiological phenomena. Why this is not happening in some women? So let's understand how this placenta is formed. The placenta is having a fetal part and the maternal part. The fetal part consists of the small, minute, microscopic blood vessels, the cotyledons, and the maternal part consists of the decidua basalis. So there is a very fine layer of demarcation between the maternal and the fetal part, that's called as a fibrinoid layer. This fibrinoid layer is responsible for the separation of the placenta at the time of delivery. In the absence of this fine fibrinoid layer between the decidua basalis and the fetal part, there is adherence of the placenta. There is also a pathology where the placental blood vessels erode and invade into the myometrium. So there could be both absence of decidua basalis, or it could be an absence of the fibrinoid layer, that is the Weetabix layer. In simple terms, it's something like a malignancy kind of a condition where the cytotrophoblasts invade and migrate and burrow into the myometrial cells as well as the blood vessels. So it was earlier called as a morbidly adherent placenta. So this is a pictorial diagram where we see the chorionic plate as well as the basal plate. So this is a microscopic examination of the placenta where you see the purple colored layer, that's the retrobutes membrane or the layer where the fine separation happens. This is a cross picture of how the placenta accreta along with the uterus being removed looks like. So there could be an absence of residua basalis, the retrobutes fibrinoid layer could be absent, and there could be varying degrees of penetration of the villi. So why is this placenta accreta spectrum more commonly seen nowadays is we have seen a tremendous increase in the number of cesarean sections, and increasing number of cesarean sections have increased the rate of placenta previa. Placenta previa is a condition where the placenta gets implanted in the lower segment of the uterus and it covers the placenta, it covers the internal os. If the placenta is present within the 2 centimeters of the internal os, it's called as a low-lying placenta, and if it covers the internal os, it's called as a placenta previa. So, how long will you observe a woman who has a placenta previa, and why is this important? When you have a placenta in the lower segment, in the early part of the pregnancy, say around 16 weeks to 20 weeks, we should never get panic and we should allow the woman to, we should reassure her and follow her up for the next few scans. At around 28 weeks of pregnancy, if you still see the placenta in the lower segment, especially in women with a previous cesarean scar, there is a high risk for her to get into this condition of placenta accreta spectrum. So this is how the placenta previa looks. So the other causes for the placenta accreta spectrum are previous uterine surgeries, done on the inside the endometrium of the uterus, that is the dilatation and curettage, manual removal of placenta, the previous myomectomies, previous Asherman syndromes who have been treated and conceived, submucous leiomyoma excision, or it could be advanced maternal age greater than 35 years or multiparity, or it could be a combination of all these. So normally the placental syncytial trophoblasts get a signal once they go into the myometrial invasion, they get a signal to stop, which is not present in all these conditions. In these conditions, the limiting aspect of the infiltration of the cyto and the syncytial trophoblasts into the myometrial cells is absent. So the main purpose of this invasion is to enable the high resistance vessels, the spiral arterioles which are present in the myometrium, to allow those spiral arterioles to become into low resistance channels, and also to help the flow of the blood, or to improve the velocity of blood flow to the developing baby. That is the nature's change which happens during pregnancy. But in all these conditions, this further migration of the syncytial trophoblasts to the innermost layer of the myometrium, as well as the vessels which are very much towards the deeper 1/3 as well as outer 2/3 of the myometrium also happens, as a result of which the blood vessels which are there towards the beginning of the uterine arteries, the initial branches of the spiral arterioles, all of them are invaded by the cytotrophoblast and the syncytial trophoblast, and the vascularity becomes so heavy or so much that the blood flow to the placenta, which is around 800 ml per minute, goes to a very high level. That is the reason when such women give birth and the placenta doesn't get separated, there is a tremendous amount of blood loss, and there will be a sudden exsanguination of the mother, as well as can cause on-table deaths. So the mortality due to this placenta accreta spectrum can vary, and we have seen about 7% of mortality in such cases. So the increase in the cesarean sections have to be first addressed, and in the next few years to come, we tend to see more and more number of these placenta accreta spectrum. So how do we again categorize or classify the placenta accreta spectrum? There could be a simple adherence of the placenta into the myometrium, which may require a simple manual removal, or it could be a condition called placenta accreta, wherein the placenta is attached to the myometrium, about 75% of the cases. Increta is a condition where the placenta invades into the myometrium and it does not reach up to the serosa, which is about 17%, and percreta is around 5 to 7%, where the placenta penetrates through the entire myometrium and also the uterine serosa. In some conditions, it can extend, it can go on to the adjacent structures like the bladder, the lateral parametrium, as well as the posterior pelvic structures. Again, they are classified as 3A, 3B and 3C. When it crosses and enters into the adjacent bladder, it is called as 3B. When it enters into the lateral parametrium, it is called 3C. When it erodes the serosa, it is 3A. So this is the pictorial diagram of accreta, increta and percreta. So how does this patient with placenta accreta syndrome, how does she behave at the time of delivery, or how do we manage such cases? There can be a heavy vaginal bleeding. It could be life-threatening, as I told before. It can cause disseminated intravascular coagulation, lung failure, ARDS, kidney failure, multiple blood transfusions. This is the extreme aspect, and for the baby it may cause prematurity. So let's know how to identify this placenta accreta spectrum. This can be done by a simple tool, that is the abdominal or a transvaginal ultrasound, which is accessible and available everywhere. So the ultrasound is very, very diagnostic and very accurate. So the percentage of accuracy is around 88 to 96% sensitivity, and specificity is around 77 to 78%. So as I said, we have to monitor all the women with the placenta previa starting from the 20th week of pregnancy, and as we progress from the 28th week of pregnancy, if we still do not see the placenta migrating above, then we have to take a call on how to counsel the women, how to involve the team, how to formulate a plan of delivery in such women. So let us know a little bit about the sonographic markers of placenta accreta. Normally the placenta, behind the placenta there is a hypoechoic zone. So this is nothing but the fibrinoid layer. On the scan it appears as a hypoechoic retroplacental zone, which is not there in placenta accreta. There could be multiple vascular lacunae. There could be thinning of the myometrium to the extent of less than 1 millimeter. There could be abnormality of the uterine serosa bladder interface. There could be a prominent bulge which is seen in the interface. And also, this is the hypoechoic zone which is seen in normal placenta, the B photograph, and in the A slide you can see that there is no hypoechoic zone. These are the multiple lacunae which are seen, and these appear like Swiss cheese pattern or moth-eaten appearance. This is the myometrial thinning. There is a very thin layer of the myometrium. This can be very well appreciated by a transvaginal scan. Here you can see the vascularity. Vascularity is so much that you can see the velocity of blood flow is very high. A very low resistance flow is seen. It can be seen as multiple high vascular zones on color Doppler. It can be seen as tortuous vessels, chaotic branching. Sometimes it's called as a Medusa head appearance. Coming to the magnetic resonance imaging. Is MRI indicated for all women with placenta accreta? No. So if there is an equivocal ultrasound finding on abnormal placentation, or in case of obese patients, or if there is a posterior placenta or a lateral placenta where you want to know the extension of the placenta in the lateral parametrium or in the posterior parametrium, it is of use, and definitely some signs in the MRI will clinch the diagnosis. So in MRI, normally the placenta on MRI appears as a homogeneous zone in T2 weighted images. The counter of the uterus is it's a pyriform counter of the uterus, and the blood vessels are very subtle. Here in placenta accreta we see dark intraplacental bands into T2 weighted images, abnormally disorganized placental vascularity, and focal interruptions of the myometrial wall and extension through the myometrium into the adjacent structures. Here you can see the placenta extending into the adjacent structures. It is almost thinning out the myometrium, and also you can see the intraplacental bands. So how do we manage now this patient who is having a morbidly adherent placenta? So we have to first get an idea as to whether it is a focal adherent placenta or it is a completely adherent placenta per creta, increta, or it is a simple accreta. So once we identify such women, it is a duty of each and every obstetrician to take the confidence of the women and their family. We have to counsel them, we have to make their family members and her sit together, explain her the condition. She requires an effort of the multidisciplinary team. She has to be managed in a hospital, in a tertiary care level, where there are facilities for multidisciplinary action. There is a facility for emergency blood bank services. Multiple blood and blood products are available. We have the other specialties available like the urology department, we have intervention radiology department, we have the best of best care in terms of anesthesia, the ICU care facilities, and also we have to tell them about the pathogenesis, the need for hysterectomy in case it is a accreta, morbidly adherent placenta resulting in a percreta or an increta. So in the antenatal period, we have to try to optimize her hemoglobin, try to give her hematinics or iron injections to see to it that her hemoglobin is well maintained so that she has the ability to tolerate some amount of blood loss during pregnancy and avoid any blood transfusion. You have to speak to her regarding the hysterectomy if it is an adherent placenta, increta or percreta. We also have to consider the preterm labor or delivery chances if she has episodes of multiple bleeding episodes during the antenatal period. Have a consultation with a pediatrician or a neonatologist and educate her about the need of NICU admission. As I said, we need to have a good team of multidisciplinary team. Giving an antenatal dose of corticosteroids when you anticipate that she has tendency to develop preterm delivery. The timing of delivery should be if she is asymptomatic, not having any episodes of bleeding, and she is well controlled with her hemoglobin, she is under good follow-up. We should plan the delivery between 34 to 35 weeks according to the ACOG. According to RCOG, it can be prolonged up to 36 plus 6 weeks of pregnancy. If this lady is in a outstation, or she is not able to access the tertiary care level, she has to be advised to come and stay near a hospital with the multidisciplinary team and stay close to the hospital and be available at any time, any point of time she has episodes of bleeding or she develops any preterm labor, she has to reach the hospital. So preoperatively, as I said, we have to optimize her hemoglobin. We have to have a planned delivery for her. We have to involve the radiology department. Internal iliac artery occlusion or balloon arterial catheterization should be planned. So normal amount of blood loss during pregnancy is around 500,000 ml. Here the blood loss can be extensive. The average blood loss in placenta accreta spectrum is around 1500 to 5000 ml. There are instances where women has lost double or 3 times the amount of blood which she has in her circulation, and the extensive amount of blood transfusion that has been given is seen to be around 20-25 packs of PRBCs. So that is the amount of massive bleeding she has at the time. So we should have facilities for FFPs, cryos, platelets that is available. As I said, we should have a very good anesthetic support, and they should be able to manage massive blood transfusion. We have a good urology setup backup for us, so we can go ahead and get in touch, or you can ligate the internal iliac artery, or go for the ureteric stenting when we feel that the placenta is invading into the bladder, and see to it that the partial bladder excision can be done with the help of the urologist. So balloon artery catheterization is again a procedure which will save a lot of blood loss at the time of delivery. So the balloon catheters are placed in the internal iliac artery, inflated. Once the delivery of the baby is done, if the bleeding is not controlled, they go ahead with the hysterectomy. These catheters will at least reduce the blood loss, and finally after the surgery is done, the balloon catheters can be removed. So normal measures which we take, like tranexamic acid, use of uterotonic agents, uterine artery ligation, internal iliac artery ligation, all these should be followed. I will jump into the medical management part. Let me go into the cesarean hysterectomy part. When we know that the placenta is not getting separated, there should be no futile efforts to remove the placenta piecemeal. You definitely would come to know on table the placenta is not getting separated. So be prepared for that. So because you know, once you start removing the placenta piecemeal, there will be extensive bleeding and the patient gets exsanguinated. So how the surgery is done, you have a pre-planned team to be there. You plan for the surgery, go ahead with the surgery, take a complete consent with the attenders with respect to the amount of blood loss, injury to the adjacent organs including the bladder, the adjacent parametrium, bowels. You also take consent for multiple blood transfusions, cesarean hysterectomy, and also prolonged hospital stay, ICU stay. Give the skin incision in the midline in a vertical manner, reach the uterus, give a classical incision on the uterus, remove the baby. If the placenta is cut in the way of the removal, first clamp the umbilical cord to prevent the exsanguination of the baby's blood. Then don't make any futile efforts to remove the placenta. You know the placenta is bulging there. So before we give an incision on the uterus, the bladder has to be completely separated very gently, and it has to be pushed down. If it is not possible, involve the urologist. You see the placenta as a bluish bulge which is seen in the lower segment. So once that is done, you have a plan intact. You go for either stepwise devascularization of the blood flow, or you can call in the urologist to go for ligation of the internal iliac artery. Immediately close the uterus and go for a hysterectomy. This hysterectomy is different from the normal hysterectomy which we do, in that the steps should be very fast. There should be clamping of all the ligaments and tying of the ligaments, which has to be quite fast, otherwise the woman will start bleeding like anything. So there are other concepts like supracervical or subtotal hysterectomy, but in such cases the bleeding happens in the lower segment because of the placenta is there in the lower segment. You need to remove the lower part of the uterus. So let me tell a little bit about the sutures which are nowadays practiced. We all know about the Beelin sutures, the Heyman sutures. Now there are vertical sutures, it's called as Ashokanand sutures, which is taken in the lateral side of the cervix, which is a vertical lateral compression suture. And you can also take sutures on the cervix transverse, it's called as a transverse Beelin suture. Or you can, if there is nothing available, you can make use of a rubber catheter, the Foley's catheter or a red rubber catheter. Make hole on both sides of the broad ligament, tie the lower segment of the uterus with a red rubber catheter and proceed with the hysterectomy. So this is the vertical suture, vertical compression suture on either sides. This is also called as the Ashokanand suture. This is the transverse Beelin suture, where similar to the vertical Beelins, which we put a transverse suture in the lower segment. We can also go ahead with this chaw stitch, which is nothing but a rectangular stitch in the lower segment, which will include a larger area of the lower segment. We all know about the Heyman suture. There's also another technique called as suturing the cervix to the lower segment, but I am not sure how it is going to be possible because it's going to be really horrible and bleeding there. These are some of the pictures of the placenta down there. You can see the vessels and also the bulge of the placenta there. These are post-operative pictures of hysterectomy specimens. So if the bladder invasion is confirmed, involve the urologist and let him do an en bloc excision of the bladder and resuture the bladder, put the Foley's for another 2 or 3 weeks. And she will require admission in the ICU, and also venous thromboembolism prophylaxis should be taken. What happens if you don't know that the patient has already had a placenta accreta? You get a surprise in the periphery or in the government hospitals, or when the patient is not having a regular follow-up visit and she visits only at the time of labor or when she lands in preterm labor, she goes to the hospital and on table you have a surprise wherein the placenta is seen as a bulge, and you know then at that point of time that there is a placenta accreta. So in such a situation, never give an incision. Take the help of the senior person who is there in the hospital, or call for help. Call the senior anesthetist. Think about the possibility of having availability of the blood transfusion. Counsel the attenders immediately. If it is not possible to have all these facilities, close the abdomen and shift her to a higher center. Rather than giving an incision and landing in a catastrophic bleed. So there are other instances where the placenta has been left in place, the uterus has been closed and conservative management has been followed, but the possibility of such women going in for complete resorption is not there. There is a 50% chance that these women may develop infections in the future, secondary hemorrhage following delivery, or these patients may get into severe sepsis also. So having this method of leaving back the placenta, giving methotrexate and following up should not be practiced for all women, because this is advocated in certain situations where you should be planning for a repeat hysterectomy or as a key surgery later, or you have a patient who is who is ready to come for a regular follow-up. So if you have removed the placenta and there is a little bit of a chunk which is left over, you can take her up for a resurgery, going ahead with a hysteroscopic resection at a later date, or you can go for a embolization of the uterine arteries, or you can go for a delayed hysterectomy. So the triple P procedure is to have a uterine sparing procedure, the placental myometrial en bloc removal, where you suspect a partial adhesion of the placenta, where you have a perioperative placental localization, pelvic devascularization, and placental non-removal with en bloc myometrial excision. So the neonatal outcome depends on what gestational age the baby comes out. If it is a preterm delivery, all the complications of the prematurity has to be explained to them, and the need for NICU is there. The deadly Ds of accreta are a delayed referral, delay in the knowledge, delay cesarean, that is, don't plan for an emergency cesarean without having a pre-plan, delayed decision for hysterectomy. Then there is a deficiency, when you have a deficiency of time availability, deficiency of blood and blood products, deficiency of ICU beds, deficiency of multidisciplinary senior team. It is better not to touch such placenta. We have to always have a plan of action for any woman who has been diagnosed with placenta accreta spectrum. So with this, I would like to thank I will conclude my talk. Thank you.
A very good afternoon to all of you. Thank you, Dr. Varalakshmi, for that very elaborate and lucid talk on placenta accreta spectrum. So basically it is very important, I think she has conveyed the message very well, that it is something which is quite dreaded, and once you have diagnosed it, it needs a very strong and so on and so forth. Most importantly, it is like in the present scenario with imaging techniques so much advanced, we should not be actually encountering a surprise accreta. It should have been diagnosed much earlier in the pregnancy itself. And the best time to catch a placenta accreta is when you see a cesarean scar pregnancy. So when you see that is why it is very important that early pregnancy scan, they look at where the implantation of the sac is, especially if it is near the cesarean scar. It is very important you tackle it at that point, and then you will not land up with the placenta accreta spectrum much later. The second thing is like there are two important ways of dealing with it. One is a known case of placenta accreta where we are ready in all ways. Like you said, the whole procedure would be followed. Whereas the surprise can still happen in spite of that, because especially if it is not on a scar. So the anterior previous cesarean placenta accreta is easier because we already have that thought in our mind. So we keep on asking the radiologist, are you sure it's anterior lower placenta? Are you sure there is no scar? It's not adherent. But whereas if it is posterior or if it is a focal, higher up, post-myomectomy or post DNCs or any procedures done in the uterus, then you might, if you should be having a very good radiologist who has to look through and through wherever the placenta is located to see if the junction is intact or not, or if it is broken. That is very, very important, and that's where the role of having a radiologist experienced in obstetrics is very much useful to us. So I think then you can think of all the alternatives based on what it is. If it is a focal, then like you said, you can remove a part of it, part of the myoma, or if you want to. And when you're thinking of leaving it behind, that is possible only to be done if the patient wants to have another pregnancy most commonly. Otherwise, it is always better to go for a in situ hysterectomy. That would be the having, if you have one live child, if that child is alive and mature enough, then I think she might agree for a hysterectomy most likely. But if it is a very preterm or if it is like the child is not alive, she might want to have continue with having the uterus still. Then you might think of just leaving the placenta in situ. But again, you have to counsel her regarding all the complications, a need for going for again another hysterectomy, and all the complications you were telling about. So I think it was, these were the thoughts that came into my mind when you were presenting, and thank you very much.
Yeah, it's a very good, excellent, comprehensive talk, Dr. Varalakshmi. So when all the situations are good and it is diagnosed, managing placenta accreta becomes it's a teamwork. But the surprises happens when it is done in a peripheral settings, where like few doctors will be missing such placenta accreta cases. Then I feel like counseling patients and immediately taking decisions for taking hysterectomy would definitely save the patient. And suppose in such cases, suppose if you are missing in the scan, how to deal with such medico-legal cases in periphery settings? Suppose if the radiologist is missing the placenta accreta cases, because we actually come across few cases. In such cases, how to deal with the medico-legal issues? I mean to say, suppose if we get surprised when we open them, we deliver the baby, and we feel it as a placenta accreta. So, if you're landing in the problems, how to deal the medico-legal issues in such cases, in missing placenta accreta cases.
Yes. So when you have a surprise on table and the woman is bleeding, then one of your assistants or somebody should go and immediately call the attenders, speak to them in the theatre. They have to explain them that this is the finding which was not being picked up, or we should not blame the radiologist, or it's not the fault of the radiologist, but this is a surprise which has been coming up. and we should be able to communicate to them in the operation theatre and take a consent then and there. Because we have the members outside standing in the theatre, you can't waste time, or you cannot, just go ahead taking out the uterus with your own, decision making is not correct. So you need to involve the members, immediately talk to them. In fact, they would also understand the intensity. They can't say that you allow them to bleed or you just don't do anything. We want the uterus to be saved. I don't think so. That would be the scenario. They would also try to understand, but the person who is communicating to them should be very empathetic and say that this is what we have noticed and this is what we are planning to go ahead, and she will require a further blood transfusion facility, or if necessary we will immediately take steps to do a hysterectomy, but again she may require a further ICU facility. We may have to shift her to a higher center. All this communication will definitely help them. So in not landing in medical legal issues.
Yeah, thank you. Thank you.
That will be good for you in the future. Yeah, I think Radhika has a good point saying that we have to take an intraoperative pictures which will help us to show the surprise which we had in the theatre. But video counseling is not always safe. It's again a double-edged sword. If you have missed out on anything, that is also will be shown on the video. So especially when you are under stress and are not prepared, suddenly you go and give a video counseling, you might miss out. So be very careful whenever you are doing a video counseling of what you are talking to the patient, because it can work in the reverse also. It has worked also. So that's one thing.
In a proper written format. If your assistant is able to put it down on the paper.
Putting down written format is also, that is there.
We can also record whatever we are explaining in our phone and keep it with us rather than handing it.
That's what I'm saying. When you're taking such a consent, be careful that you are not missing out anything. Whichever format, please be careful. That's what I wanted to convey. And one thing for what you are saying is, if you are finding a placenta which is adherent and you're not able to take it out, don't attempt.
Yeah.
Just clamp it and close the uterus and shift her. You can send her to a tertiary center. In the meantime, the patient can be counseled, the editors can be counseled. If they are very resistant and not agreeing, do not attempt to remove the placenta at all. You can always do a second sitting.
Thank you, ma'am. Thank you very much.
Thank you.
I request the moderators to please be seated. I will now welcome Dr. Sindhuri, a consultant gynecologist, who will be sharing her insights on abruptio placenta, a crucial yet life-threatening obstetric emergency. Hello everyone. Today I am going to talk about abruptio placenta, which is an obstetric emergency. Coming to the definition, abruptio placenta is the premature separation of normally implanted placenta from the uterine wall after the 20th week of gestation until the second stage of labor. This is a picture of normally situated placenta, whereas the second one showing the picture of detached placenta. Coming to the incidence, overall incidence of placental abruption ranges from 0.5% or 1 case in 200 deliveries. Women with abruption and fetal demise have recurrence rate of 12%. For women who had 2 severe abruptions, the risk for a third was increased by 50-fold. Etiological factors. Primary cause of abruptio placenta is uncertain. Several associated conditions are identified. First one is the increase in age and parity, preeclampsia, chronic hypertension, PRON, multifetal gestation,
then cigarette smoking, cocaine abuse, prior history of abruption, uterine fibroids and polyhydramnios. Coming to the types of abruption, there are 3 types: reveal, concealed and the mixed type. So reveal type where the bleeding is revealed. Coming to the concealed type, no, there is no obvious bleeding. In mixed type, it's a basically combination of reveal and concealed. So concealed variety, which is less common, 20% of the cases, the hemorrhage is confined within the uterine cavity. Detachment of placenta may be complete and the complications are often severe. Whereas in revealed type, which is more common than concealed type, the blood drains through the cervix. Placental detachment is more likely to incomplete and the complications are fewer and less severe. So here are the pictures showing of concealed hemorrhage, revealed hemorrhage and mixed hemorrhage. So coming to the grades of placental abruption, according to the Page's classification, it is divided into 4 grades, grade 0, 1, 2 and 3. Coming to the grade 0, it's usually asymptomatic and retrospective diagnosis, no signs and symptoms. Fetus and placenta subsequently are delivered and only upon inspection of the placenta is a retroplacental clot formed. Coming to the grade 1, no signs of maternal or fetal distress as such. Mild symptoms may be present, minimal to no vaginal bleeding and slight uterine tenderness. No signs of maternal distress, maternal heart rate and BP are normal and no signs of fetal distress. Whereas coming to the grade 2, no signs of maternal shock but fetal distress is present. Moderate symptoms, no vaginal bleeding to moderate vaginal bleeding, significant uterine tenderness and increased uterine cavity is seen. And there is no maternal shock, fetal heartbeat is present, fetal distress is seen and CTG changes like late decelerations or sinusoidal pattern is seen and uterine activity may be increased. Coming to the grade 3, maternal shock and usually intrauterine death is seen. Obvious or severe symptoms like vaginal bleeding, sudden onset of lower abdominal or back pain and uterus is woody, hard in feel and tender. Maternal shock may be seen, no fetal heartbeat present and it is categorized into subtype A and B. Whereas in subtype A, no coagulopathy is seen, whereas in subtype B, coagulopathy is present. Coming to the pathogenesis of abruptio placenta, etiological factors causing hemorrhage into the deciduo basalis and hematoma formation, which causes degeneration and necrosis of deciduo basalis with adjacent placenta, which causes rupture of basal plate, forming communication between hematoma and intervillous space. Fluid and blood percolate into myometrium up to serous cord, causing cubular uterus, and sometimes serosa split open and blood enters into the peritoneal cavity. Coming to the pathophysiology, local vascular injury lead to hematoma formation in deciduo basalis, cause suppression of placenta. Also the venous engorgement and abrupt increase in uterine venous pressure also leads to the suppression of placenta. Coming to the Cuvillate's uterus, also called uteroplacental apoplexy, first described by Cuvillate in early 1900. It is an extravasation of blood into the uterine musculature and beneath uterine serosa, demonstrated only at laparotomy. These myometrial hemorrhage interfere with uterine contractions to produce postpartum hemorrhage. This is a picture of cuvular uterus, which is usually port wine in color, and the other picture showing the cut section of Cuvillate's uterus. Coming to the clinical features, it is acute or chronic. Clinical presentation wise, it could be concealed or revealed or mixed. Coming to the severity, mild, moderate or severe. So, symptoms of acute abruption, usually vaginal bleeding is seen, abdominal pain, uterine contractions, uterine tenderness, tachysystole, non-reassuring fetal heart rate pattern and fetal death. Chronic abruption symptoms, it's usually insidious in onset, associated with ischemic placental disease, intermittent light vaginal bleeding with signs of chronic placental inflammation and dysfunction. Also usually it's seen in oligohydramnios, IUGR cases, preterm labor, premature preterm rupture of membranes and preeclampsia. Coming to the maternal complications, maternal mortality is seen, hypovolemic shock, renal failure, DIC, postpartum hemorrhage, resensitization, and complications of massive transfusion. Whereas fetal complication includes fetal death, hypoxic brain injury, IUGR, neonatal anemia, and congenital malformations. Signs and symptoms of the vaginal bleeding we see in 78% of the cases, uterine tenderness, 66% of the cases, back pain, then fetal distress, hypertonic uterus, and fetal demise in 15% of the cases. Coming to the DD of abruptio placenta, number one is the placenta previa, sometimes labor also may be confused, and then uterine rupture, and the other one is a vasa previa. So the most, another common cause of antepartum hemorrhage is the placenta previa. So coming to the differences between placenta previa and abruptio placenta, usually in placenta previa the bleeding is painless, causeless and recurrent, always revealed, and it's bright red in color, often ceases within 1 to 2 hours, and the height of the abdomen is proportionate to the gestational age. Usually the feel of the uterus is soft and relaxed, and head is high floating. Fetal heart rate is usually present and normal. DIC is rarely seen, and on ultrasound placenta is seen in the lower segment, and on vaginal examination placenta felt on the lower segment. Coming to the abruptio, always the nature of the bleeding is painful, continuous, and could be revealed or concealed, and color of the blood is dark colored, out of proportion in concealed or mixed, present in 1/3 of the cases, and usually the bleeding is continuous. Whereas on abdominal examination, height of the uterus is disproportionate to the gestational age, especially in concealed abruption, and the feel of the uterus is tense, tender and rigid. Fetal heart rate is absent and concealed, and loss of variability is seen, and decelerations are seen in the CTG, and intrauterine fetal death can be seen. In severe cases, associated history could be seen in severe cases like trauma, hypertension, multiple gestational polyhydramnios, and DSA possibility is more in abruptio than placenta previa, and on ultrasound placenta is in the upper segment only, and placenta is not felt on the vaginal examination. Coming to the diagnosis, primarily diagnosed clinically only, may be supported with radiographic, laboratory and pathological studies. Basis of diagnosis consists of history and physical examinations, then triad of symptoms like external bleeding through cervical loss, uterine or back pain, and fetal distress should be of high suspicion. Defer digital cervical examination until placenta previa and vasa previa are ruled out. Ultrasound has limited value, but for large abruptions, hypoechoic area seen underlying placenta. So this is a picture. Above it is showing the retroplacental clot. And in placenta we can see the blood clot in this picture. So coming to the laboratory test, CBC should be sent, blood typing and screening, urine analysis, liver LFT, RFT, PT, APTT, INR, CTBT should be sent, fibrinogen level should be monitored, and fibrin degradation products and Clay-Hair Bit test in case of RH negative mother to rule out feto-maternal hemorrhage. And coming to the pathology, in gross pathology, adherent clot and depression on the placental surface is seen. Histology, there signs of chronic deciduitis, maternal floor decidual necrosis, villitis, decidual vasculopathy, and infarction can be seen. Preservation of the villus stroma, eosinophilic degeneration of cincture trophoblast, and scattered neutrophil with villus agglutination. Coming to the management, depends on condition of mother and gestational age of the fetus. So first we have to secure large bore IV access should be obtained. Fluid resuscitation is necessary, typing and cross-matching blood for possible transfusion, steroids for lung maturity in case of preterm, Foley's catheterization should be done, maternal vitals close monitoring, continuous fetal heart rate monitoring, and RHD immunoglobulin administered to RH negative patients. So in case of term gestation and patient is hemodynamically stable, plan for vaginal delivery with C-section for usual indications, follow serial hematocrit and coagulation studies, and continuous fetal monitoring should be there. Term gestation and hemodynamically instability, aggressive fluid resuscitation, transfuse packed red blood cells, FFPs and platelets as needed, maintain fibrinogen level more than 150 mg per deciliter, hematocrit more than 25% and platelet over 60,000 per microliter. urgent cesarean section unless vaginal delivery is imminent. Whereas in case of preterm gestation and patient is hemodynamically stable, in absence of labor, preterm abruptio should be followed with serial ultrasound for fetal growth. Steroids should be given to promote fetal lung maturity. Magnesium sulfate if less than 32 weeks for neuroprotection. If maternal instability or fetal distress arises, delivery should be performed. If not, labor can be induced at term. Preterm gestation and hemodynamically unstable, delivery should be performed after appropriate resuscitation. So let's discuss few case scenarios. Coming to the first case scenario, in case of mild abruption and the mother and fetus are stable. So a patient of 30 years old, gravida 2 para 1 at 34 weeks of gestation, symptoms like mild vaginal bleeding and no pain. Fetal status, there is a reassuring CTG and ultrasound shows small retroplacental clot. So the management includes admit for observation, administer corticosteroids, monitor fetal well-being with NST and modified BPP daily, serial hemogram, coagulation profile, plan delivery at 37 weeks if there is no deterioration. Case scenario regarding moderate abruption with threatened fetal distress. Patient of 27-year-old, gravida 1 at 36 weeks of gestation, symptoms like mild vaginal bleeding, uterine tenderness, stable vitals, whereas variable decelerations on CTG. So the management part includes admit to labor ward, continuous fetal monitoring, establish IV access, send investigations, prepare for potential emergency C-section. If fetal tracing improves and labor is favorable, then ARM should be done and attempt vaginal delivery. If worsening, then proceed with the C-section. Coming to the case scenario 3, it's regarding severe concealed abruption with intrauterine fetal death. So a 35-year-old patient who is gravida 3 para 2 at 38 weeks comes with severe pain, rigid uterus and no bleeding, and vital shows hypotension and tachycardia, fetal status, absent fetal heart rate. In such conditions, management includes confirm fetal death with ultrasound, stabilize mother with IV fluids and blood transfusions, monitor for DIC by sending platelets, PT, prothrombin time and fibrinogen, prefer vaginal delivery unless contraindicated, provide emotional support and counseling, and if vitals are worsening and there is no scope for vaginal delivery, then proceed with the C-section and carefully monitor for postpartum hemorrhage. Case scenario 4, chronic abruption with fetal growth restriction. So a patient of 26-year-old, gravida 2 para 1 at 32 weeks, complained with squatting for 1 week, decreased fetal movements, ultrasound showing fetal growth restriction, old retroplacental clot and decreased amniotic fluid, stable vitals and normal CTG. So in this case, we manage patient, admit for close monitoring, administer corticosteroids, serial fetal Doppler and biophysical profile, magnesium sulfate if less than 32 weeks, delivery if fetal parameters deteriorate, or deliver at 36 to 37 weeks. So if in case of severe abruption with maternal coagulopathy, a patient of 33-year-old, gravida 4 para 3 at 37 weeks, who is hypotensive and there is a prolonged bleeding with low platelet count, low fibrinogen, elevated PT and APTT, and there is a bradycardia. Then management includes emergency C-section, transfusion of packed red blood cells, FFP, platelets, cryoprecipitate, monitor for DIC and acute renal failure, ICU post-op care should be there, consider hysterectomy if uterine atonia and uncontrollable hemorrhage is there. Coming to the DIC, which is the most serious complication of abruptio placenta if not managed properly, then abruptio, the triggers known to precipitate DIC in abruptio includes tissue thromboplastin liberated from the retained blood clot or damaged placenta within the uterus and absorbed into the bloodstream, causes widespread microcoagulation throughout the entire vascular tree. Consumption of all coagulation factors by the clot leading to consumptive coagulopathy and consumption of these factors leading to defective coagulation coupled with bleeding in abruption leading to DIC. Clinical manifestations of DIC include petechia, purpura, ecchymosis, hemorrhagic bulla and subcutaneous hematoma. Signs of surgical or traumatic wound bleeding or bleeding from venipuncture sites may present with shock and acidosis. Laboratory testing DIC, peripheral smear and platelet count show thrombocytopenia, leukocytosis, histiocytes. Platelet count may fall below 20,000. Prothrombin time 11 to 16 seconds. PTT 22 to 37, and fibrinogen level usually hypofibrinogenemia is seen, and D-dimer assay should be sent. Management of DIC. Treatment consists of correction of underlying problems. Simultaneous supportive treatment is vital to restore the circulatory system, maintain blood pressure and electrolyte balance. Transfusion of blood and blood products. So packed red blood cells should be transfused in case of anemia or ongoing bleeding. And FFP's dose is usually 10 to 15 ml per kg if INR is more than 1.5 or prolonged PT or APTT with bleeding. Platelets. Platelet transfusion should be done if less than 50,000 per microliter and actively bleeding, or less than 20,000 per microliter even without bleeding. And massive transfusion protocol should be followed if estimated blood loss is more than 1500 ml or requiring more than 4 units of packed red blood cells in 1 hour, or hypotensive unresponsive to the fluids, then deliver blood products in 1:1:1 ratio. 1 unit of packed red blood cells followed by FFPs followed by platelets, again in repeat. Coming to the fibrinogen replacement therapy, severe hypofibrinogenemia, that is less than 100 mg per deciliter in DIC, can be corrected with cryoprecipitate or fibrinogen concentrate after failed treatment with FFP, with the target to keep levels above 100 mg per deciliter. Fibrinogen replacement therapy can be provided intravenously using FFP, cryoprecipitate and fibrinogen concentrate. FFP, 1 unit of FFP raises fibrinogen levels by 10 mg per deciliter. Cryoprecipitate, each unit raises fibrinogen level by 10 mg per dl. Fibrinogen concentrate, initial dose is equal to target fibrinogen minus measured fibrinogen by correction factor. Conclusion. Abruptio placenta is an important cause of fetal and maternal morbidity and mortality. The etiology is poorly understood. Various management options are however available. Early recognition, prompt clinical assessment and appropriate management are essential to improve outcomes. Multidisciplinary care and timely delivery remain the cornerstone of effective management. Thank you.
Thank you very much for that elaborate case scenarios. So I think the most important case scenarios here are the chronic abruption, which is a bit tricky because we don't know what will happen and how it will land up. May land up with fetal complications more. And the other one is severe abruptio. So as far as severe abruptio is concerned, I have one thing to say usually, which I tell my postgraduates also. Always whenever you see a bleeding, do a bedside clot test. So don't wait for the lab test. This bedside clot test has been there from, I think, from much before, even before my time. So when we were postgraduates, we used to do bedside clot test and go ahead with the treatment management. So similarly, you can do that simple test. Don't wait because labs take a longer time. That will give you a clue if she will, if she's having any lysis, or if she needs any immediate FFPs or whatever, platelets or whatever might turn out to be deficient. So that's the best hint you will get. And if it is normal, try to deliver her immediately. That is the best thing I would say. And if they're abnormal, if the bedside clot test is abnormal, then you wait for the labs. In the meantime, arrange for all this whatever your massive transfusion protocols say. But remember, even massive transfusion protocols have their own complications, like lactic acidosis, electrolyte imbalance. That also can cause coagulopathies. So many problems are there. And when you're choosing between FFP and cryo, maybe you should choose cryo whenever you don't want to give a fluid overload. So if your fluid is not a problem, then FFP is easier. Otherwise, go for cryo. This is a things that I thought I should add. Most important thing is, again, look at the urine output, always catheterize and deliver her as fast as possible. Thank you very much.
Thank you. Thank you.
Can we leave?
Thank you, Dr. Varghese. Varalakshmi, for your insightful and practical session on placenta accreta spectrum. Your expertise in high-risk obstetrics and case-based approach brought great clarity to this complex condition. I also thank Dr. Sindhuri for her enriching presentation on abruptio placenta. Your presentation helped us better understand the timely diagnosis and effective management. Our heartfelt thanks to Dr. Krishna Kumari ma'am and Dr. Maithili ma'am as well for skillfully steering the session and fostering an engaging and informative discussion. I now request Dr. Venkat, our Medical Superintendent, Medicover Women and Child Hospital, to present the memento to our moderators, Dr. Krishna Kumari and Dr. Maithili. Dr. Meenakshi ma'am, may I request you to present the mementos? Dr. Varalakshmi ma'am and Dr. Sindhuri ma'am. Tea and refreshments at the back of the hall as we keep the sessions going strong.
Break live.
As we move to our next session on today's scientific program, we turn our focus to a condition that remains clinically challenging and deeply significant in reproductive medicine, that is recurrent pregnancy loss. We are privileged to have with us Dr. Savita ma'am, consultant gynecologist, whose rich experience in high-risk obstetrics and gynecology will guide us through the various etiological factors, also along with the latest diagnostic protocols aimed at uncovering root cause with precision and clarity. I would also like to invite Dr. Anusha Reddy ma'am, who will be moderating this session, to welcome on to the stage, please.
Good evening, everyone. First of all, I would like to thank the management of Medicover Women and Child for organizing this wonderful conference. And I would also like to take this opportunity to thank the delegates for taking your time out to attend this enriching conference. Today, my topic is something which is emotionally sensitive and also clinically important. I will be dealing about recurrent pregnancy loss, the causes and the evaluation. So I am Dr. Savita Rathod, working as obstetrician and gynecologist at Medicover Women and Child Hospital. So early pregnancy loss, it is has a phenomenon of iceberg, wherein almost about 50 to 60% of the pregnancy losses occur even before the woman realizes that she's pregnant. It is seen in about 30% of the women undergo pre-implantation failure and 20% have post-implantation failure. This is when the woman does not recognize that she is pregnant. While the clinical that we see is only about 40 to 50% of the cases, that is the ones which end up is miscarriage, and the live births account for only 30% of the pregnancies. So pregnancy can be clinical pregnancies or biochemical pregnancies. Failure of a clinical pregnancy is miscarriage, and biochemical pregnancies, it is seen in about 60% of the general population, and it is not considered as miscarriage. This is a topic which is filled with controversies right from the definition up till the management. So according to the guidelines, that is RCOG, it defines recurrent pregnancy loss as loss of 3 or more pregnancies. Earlier consecutive term was used, but now they refrain from using the term consecutive pregnancy losses. And ASRM and ESHRE stick to the definition of loss of 2 or more pregnancies. These losses include the molar pregnancies and the biochemical pregnancies. However, ectopic pregnancies are not included in this definition. RPL can be further divided as primary and secondary. Primary RPL includes the pregnancy loss in women who have never carried up to the period of viability. However, secondary RPL, it's women who has had a previous live birth, and the prognosis is better with in a woman who has had secondary RPL. Coming to the incidence of pregnancy loss, we see about 15% of the pregnancies end up in miscarriage in about 15% of the patients, and if we consider 2 first trimester losses as RPL, then it is seen in about 2% of the women, and 0.4 to 1% of the women experience 3 first trimester miscarriages. The prevalence of miscarriage, it is higher with increasing maternal age and at very early gestation age. For example, less than 6 weeks, the risk of miscarriage is about 22 to 55%, while more than 10 weeks, it is seen in about 2 to 3% of the cases. And why does the sporadic pregnancy loss occur? 50% of the first trimester abortions are due to the aneuploid embryos. This is because the rate of aneuploid oocytes increases as the age advances, and thereby the rate of miscarriage, when you see in a woman who's aged around 20, is somewhere around 10%, and it goes beyond 90% in a woman who's over 45 years of age. So moving to the risk factors and etiology. In about 40 to 50% of the cases, we do not have a cause, and it is defined as unexplained recurrent pregnancy loss, while the other factors include genetic factors, anatomic, autoimmune, infectious, and endocrine factors. Epidemiological factors, these also play a major role in recurrent pregnancy loss. As I said, advancing maternal age is associated with aneuploid embryos and oocytes, and thereby leading to the increased risk of miscarriage. Similarly, advancing paternal age more than 45 years is considered as a risk factor for miscarriage, although it is not as significant as that with the maternal age. Number of previous miscarriages also increase the risk of subsequent miscarriages. Previous live birth has no association with subsequent miscarriage risk, and therefore the term consecutive pregnancy loss has been removed from the RCOG definition. Black ethnic group in comparison with the Europeans have increased risk of miscarriage. Consanguineous relationship, there is no increased risk of miscarriage. The lifestyle factors like smoking, excessive alcohol consumption, and caffeine consumption more than 200 mg per day is associated with increased risk of miscarriage. And women with a BMI less than 19 or more than 25 are at increased risk of recurrent miscarriage. Environmental exposure to chemicals like lead, arsenic are also associated with increased risk of miscarriage, although the studies have limited data on their evidence. Moving on to thrombophilia, there are many autoimmune conditions which are linked with the adverse pregnancy outcome, but there is only one condition, that is APLA, or the antiphospholipid syndrome, which has pregnancy loss as a criteria in its diagnosis. So we define antiphospholipid syndrome as the association of antiphospholipid antibodies, that is the lupus anticoagulant, beta-2-glycoprotein 1 and anticardiolipin antibodies, and the adverse pregnancy outcome or vascular thrombosis. This accounts to about 5 to 15% of RPLs in association with APS. So the adverse pregnancy outcomes, it includes 3 or more consecutive miscarriages before 10 weeks of gestation, 1 or more morphological normal fetal loss after the 10th week of gestation, 1 or more preterm births before 34 weeks of gestation because of a placental disease. So the mechanism by which antiphospholipid antibodies cause pregnancy morbidity include inhibition of the trophoblastic function and differentiation, Activation of complement pathways at the maternal-fetal interface resulting in local inflammatory response. In later pregnancies, thrombosis of the uteroplacental vasculature. Of the three antiphospholipid antibodies, lupus anticoagulant has the strongest association with recurrent miscarriage, followed by anticardiolipin antibody. There are various inherited thrombophilias, but the association with recurrent pregnancy loss is not very clear. And the factor V leading mutation, prothrombin gene mutation and protein S deficiency have been associated with second trimester miscarriages rather than first trimester. And however, there is no association between protein C, methylene tetrahydrofolate reductase and antithrombin deficiency in cases of recurrent miscarriages. Moving on to genetic factors, the fetal chromosomal abnormalities, these are the most common cause of both sporadic and recurrent miscarriages, and it accounts for about 50% of the sporadic miscarriages, especially in the first trimester. Among those with these anomalies, the decreasing order of frequency include trisomy, polyploidy, monosomy, structural anomalies and others. Aneuploidy, the risk increases as the number of previous miscarriages increases, and miscarriage of a euploid pregnancy is associated with an increased risk of subsequent miscarriage. This means that if a chromosomal product has shown any aneuploid fetus, it has a better prognosis in the subsequent pregnancy rather than finding the euploid loss its association with the subsequent pregnancy. Parental chromosomal rearrangements. 3 to 5% of the couples with recurrent pregnancy loss, usually a balanced translocation like Robertsonian or reciprocal translocation, or less commonly an inversion, is associated with recurrent pregnancy loss. One or both partners may harbor the lethal genes in heterozygous or balanced combination that does not affect them, but when this is inherited by the embryo in a homozygous or unbalanced state, can be lethal and lead to pregnancy loss. It is seen more commonly in female than male, and it is more likely to result in a pregnancy loss if the translocation is of maternal origin. Therefore, if there is any translocation in the X chromosome, the male embryo or the male fetus is likely to be more affected than the female carrier. So this is a pictorial depiction of how the balanced translocation carrier can lead to the lethal partial monosomy and partial trisomy if it is unbalanced. While if it is a balanced carrier, or if it is normal, then it is not lethal in the fetus. So RPL, being related to parental karyotype abnormality, appears to be higher when there is young maternal age at second miscarriage, there is a history of 3 or miscarriages, or a history of 2 or more miscarriages in a sibling or parents of the either partner, or a family history of stillbirth or an abnormal live-born child. Anatomical or the uterine factors, the congenital uterine anomalies and the acquired, these constitute about 10 to 15% of the recurrent pregnancy loss. Of the congenital uterine anomalies, septate uterus is the most commonly associated, and it is associated with the poorest reproductive outcome. And this is one abnormality which can be identified and can be corrected. So these are often detected on a routine ultrasound, and these also can be detected at the time of hysterosalpingogram and further characterized by MRI or 3D imaging. And a septate uterus is amenable to hysteroscopic surgical correction, and however there are no corrective options for the unicornate or the didelphic uterus. Inherited uterine anomalies, these include the leiomyoma, adenomyosis, endometrial polyp, and the intrauterine adhesions or the Ashermans. So leiomyomas, mostly the submucous ones, it can impede the normal implantation, thereby reducing the blood flow and the implantation. Adenomyosis, the role of adenomyosis causing RPL, it is because of the inflammatory changes in the endometrium. Endometrial polyps, there is no data showing a relationship between the polyp and RPL. Intrauterine adhesions, these are most commonly seen after dilatation and curettage, and the reason why it can lead to RPL is that there is insufficient endometrium to support the fetoplacental growth. So the curettage that is done, it traumatizes the basalis layer, and this heals by the formation of granulation tissue. The granulation tissue, it fuses and then producing tissue bridges, which could be flimsy or it could be dense adhesions due to the formation of connective tissue. So the partial or complete obliteration of cavity leads to menstrual irregularity, cyclic pelvic pain, and also infertility and recurrent pregnancy loss. The clinical management of pregnancy loss associated with RPL with Asherman's or the uterine fibroids and polyp is controversial, and there is no conclusive evidence that surgical treatment reduces the risk of pregnancy loss. However, because the randomized controlled trials are lacking, there is a general consensus that surgical correction of significant uterine cavities should be considered. Cervical integrity. The cervical integrity, it is recognized as one of the most common cause of second trimester miscarriage, but the true incidence is unknown since the diagnosis is a clinical one. There is no satisfactory objective test that can identify women with cervical weakness in the non-pregnant state. The diagnosis is based on a history of second trimester miscarriage preceded by spontaneous rupture of membranes or cervical dilatation. Defective endometrial receptivity. Normally estrogen and progesterone are required for the proper formation of the endometrium, and when the endometrial receptive is defective, it can result in unexplained infertility and recurrent pregnancy loss. The causes of defective endometrial receptivity and biomarkers for evaluation are under investigation. This could be a place where the future can help in knowing the causes of unexplained infertility. Moving on to endocrine factors, systemic maternal endocrine disorders such as diabetes and thyroid have been associated with miscarriage. There is an association between thyroid dysfunction or thyroid autoantibodies and RPL. Women with diabetes who have high HbA1c levels in the first trimester are at risk of miscarriage and fetal malformation. Polycystic ovarian syndrome has been linked to an increased risk of miscarriage, but the exact mechanisms remain unclear. It could be because of the increased LH, testosterone level, and insulin resistance. However, well-controlled diabetes mellitus is not a risk factor for recurrent miscarriage, nor is treated thyroid condition. However, the prevalence of diabetes mellitus and thyroid dysfunction in women who suffer recurrent miscarriage is similar to that reported in the general population. So these are the various risk factors, like well-controlled diabetes and thyroid have no increased risk of recurrent miscarriage. Subclinical hypothyroid is associated with the increased risk of recurrent miscarriage. Thyroid autoantibodies, even in the presence of euthyroid patients, can be a risk factor for recurrent miscarriage. PCOD has an increased risk. Prolactin imbalance is also associated with increased risk. The prolactin levels, if we target to have lower levels in the early pregnancy, can prevent miscarriages and have a healthy life child. Luteal phase defect, there is inconclusive evidence to prove or its association with RPL. Immune factors, any stage of the pregnancy can have an immune reaction. Normally the blastocyst, the embryo is covered with a trophoblast and it is clear and intact. If there is any defect in the blastocyst, it can expose the paternal cells to the maternal immune system and thereby leading to a graft rejection-like reaction. So the immunological screening like HLA, cytokine and natural killer cell tests are not routinely offered, and this is only in the context of research purposes that it is done. Infective factors, any severe anemia or viremia can cause sporadic miscarriage. For an infective agent to be implicated in the etiology of repeated pregnancy loss, it must be capable of persisting in the genital tract and avoiding detection, or the women must be asymptomatic so that it can be picked up. So none of the infections of the torch like the toxoplasmosis, rubella, cytomegalovirus, herpes, listeria fulfill these criteria, and therefore routine screening for torch is not recommended. Bacterial vaginosis, its presence in the first trimester has been reported as a risk factor for secondary endometrium associated with a range of pathogenic organisms, and its prevalence is seen in about 7 to 8% of the women with RPL. And further molecular studies on the microbiome of uterine cavity will hopefully shed some more light into the role of infections in recurrent miscarriage. Male factor, the sperm parameters like viability, normal morphology, motility, acrosomal status are lower in men experiencing recurrent miscarriage versus controls, and this is a limited data. However, increased sperm DNA fragmentation is associated with increased risk, and this is another promising factor which can help us identify the cause. Moving on to the evaluation includes the history and physical examination. Medical and family history can be used to tailor the diagnostic investigations in women with RPL. Age is an important factor. As the age increases, the chances of RPL increases. Lifestyle of factors of both the partners is essential. Menstrual history is to be taken because irregular cycles can indicate endocrinopathy or PCOD. Obstetric history is of utmost importance. We need to know the gestational age when the pregnancy loss occurred, because the recurrence usually occurs at the same gestational age, and chromosomal endocrine defects occur most commonly in the first trimester, while the anatomic or immunological are more common in the second trimester. However, there can be significant overlap. Embryonic cardiac activity, whether it was detected before the miscarriage occurred or not, is also essential, because fetuses which do not have the cardiac activity are more likely to be chromosomal abnormalities more associated with such fetus. Medical history is important because the venous or arterial thrombosis, diabetes, thyroid dysfunction can be identified, and then this can pose a risk for RPL. Any history of surgical intervention to know whether there could be a possibility of intrauterine adhesions, family history, and also to look for the previous investigations and any treatments that the woman has undergone. Moving on to the physical examination, general physical examination is important to look for the signs of endocrinopathy like hirsutism, galactorrhea, and also for any chromosomal abnormalities. Pelvic organ examination to look for uterus and any uterine malformation like the Mullerian anomalies, and also the cervical laceration, which could be a cause of cervical incompetence. And it is also very important to assess the mental health condition of the women, because this RPL, it is a very emotionally sensitive thing for the family and the couple. So, screening for the genetic factors, genetic analysis of pregnancy tissue, it is not routinely recommended for every miscarriage, but it can be done for explanatory purpose, and it is done by CGH. Parental karyotype, after individual risk assessment, if the previous child is associated with congenital abnormalities or unbalanced chromosomal abnormalities, or there is any translocation in the pregnancy tissue. So cytogenetic analysis should be offered on a pregnancy tissue of the third and subsequent miscarriages and any second trimester miscarriage. In recurrent miscarriage, parental peripheral blood karyotyping should be performed for couples in whom testing of pregnancy tissue reports an unbalanced structural chromosomal abnormality. The finding of subsequent abnormal parental karyotype should prompt a referral to the clinical geneticist. ARIS-CGH is the preferred technique because it can be done even if the culture is negative, because this test does not include the dividing cells. And once the karyotype, even if the karyotype comes normal, this is very sensitive to pick up any abnormality. So first miscarriage, usually no action is taken unless clinically indicated. In a second miscarriage, the products of conception can be obtained and sent for microarray testing. And if aneuploid products of conception are found, then no further evaluation is required. However, if there is any unbalanced chromosomal translocation or inversion, perform parental karyotypes. If the product of conception is euploid, the remaining workup of the RPL should be done. So thrombophilia screening, hereditary thrombophilias like the factor V Leiden mutation, prothrombin mutation, methylene tetrahydrofolate reductase, and protein C, protein S, antithrombin 3 deficiency, these are not routinely recommended, but if there is any family history or any personal history of thrombosis, then in such cases investigating for the cause of thrombophilia is indicated. Acquired thrombophilia, that is to look for APLA, that is the antibodies, lupus anticoagulant, anticardiolipin and anti-2 beta glycoprotein 1. This is recommended in every case of miscarriage, and it is ideally done after 6 weeks of pregnancy, and the test has to be repeated 12 weeks apart for a confirmation, and that is when it is said whether it is positive or negative. So all women with recurrent first trimester miscarriage and all women with one or more second trimester miscarriage should be screened before pregnancy for antiphospholipid antibodies. Immunological screening, anti-nuclear antibodies and the HLA, these are not routinely recommended, but HLA class 2 determination, it is done in Scandinavian women after the birth of a boy for prognostic purposes. Other HLA, natural killer cell antibodies and cytokines, these are not routinely tested. Celiac disease, it is seen that if it is identified, the treatment of celiac disease is associated with a good outcome and it prevents the miscarriages, but there is no evidence to test for its antibody. Metabolic and endocrinological screening, women with recurrent miscarriage should be offered thyroid function test and assessment for thyroid peroxidase antibodies. Abnormal TSH levels should be followed up by T4 testing. Although the presence of TPO antibodies in euthyroid women may not warrant treatment, knowing the antibody status allows for the stratification of women and people who will require thyroid function monitoring during pregnancy. Other endocrine assessments are not routinely indicated unless there is a clinical suspicion of pathology like diabetes or hyperprolactinemia. So, although there is association with the PCOS, we do not routinely test for it, and vitamin D has a possible association, and vitamin D supplementation is important in cases of miscarriage. Ovarian reserve, the testing for AMH or the antral follicle count, it is not routinely recommended. Luteal phase insufficiency testing by endometrial biopsy has inconclusive evidence. Screening for anatomical disorders, congenital uterine malformations. Uterine cavity assessment is done in all the women, and 3D ultrasound has got high sensitivity and specificity because it can differentiate the septate and bicorporeal uterus. Sonohysterography is more accurate than HSG because it can also delineate the outer surface of the uterus, while HSG can only tell about the interior contour of the uterus. MRI, if 3D ultrasound is not available. In cases of Mullerian anomaly, if any suspicion, renal tract assessment should also be done. In cases of acquired uterine malformations, all of the women should have at least a 2D ultrasound to rule out any uterine abnormalities. Cervical screening, since it is a diagnosis which is a clinical one and it is based on the history, we do not have any objective test in the non-pregnant state. Male factor, assess lifestyle factors in the male partner like the age, smoking, alcohol, exercise and BMI, and correct these lifestyle changes because high sperm DNA fragmentation is associated with adverse outcome, and these it can be corrected by changing these lifestyle factors. So sperm DNA fragmentation, it is considered for diagnostic purpose, but we do not currently have any correct assay of SDF. So this is just a gist of the investigations that are required. So genetic analysis is done for the pregnancy tissue in second and third cases of pregnancy loss, and if any abnormality is detected, then parental testing is done. Hereditary thrombophilia checked only if there is a family history of thrombophilia or personal history of VTE without triggering factor. Acquired, it is done in every case. And endocrine factors in cases of TSH is done in case of hyper and subclinical hypothyroidism. Diabetes testing HbA1c, it is recommended. And prolactin levels have to be checked if there are any symptoms of hyperprolactinemia. And uterine factors need to be assessed with ultrasound or MRI if required, and DNA fragmentation. So this is a similar thing. And this is a comparison of ESHRE, RCOG and ASRM guidelines, which recommend the testing of parental karyotype, antiphospholipid assessment, thyroid and glucose challenge test. However, the torch is not recommended by any of the bodies, and it also does not recommend testing for the hereditary thrombophilias. So the aim of these clinical practice guidelines is to aid healthcare professionals in everyday clinical decisions about appropriate and effective care of their patients. However, adherence to these does not guarantee a successful or specific outcome, nor does it establish a standard of care. Clinical practice guidelines do not override the healthcare professional's clinical judgment in diagnosis and treatment of particular patients. The information provided in this document does not constitute business, medical or other professional advice, and it is subject to change. And these are my references. So medicine is a science of uncertainty and an art of probability. Thank you very much.
Yes. Dr. Savita, this was really a good and excellent elaborative presentation. So a few points I would like to add. I mean, like, this is all been covered just for the juriors who are here. First, when you want to evaluate any patient, choosing the patient, and when they come to the OPD itself, you just counsel both the couple, because it is a emotional turmoil for the couple and whole family as well. And over treating or under treating is also not correct. So many of the times I've seen like 2-3 miscarriages also they would have not been evaluated. They give only simple ultrasound and thyroid function tests or endocrinology, and they don't go into detail. So whenever, if you see any patient above 35 age, even one miscarriage plays crucial role. So even one miscarriage also thorough investigation is required. And over investigation also is not correct. If you think that young girl with multiple miscarriages, and many of the times I have seen people missing the sperm fragmentation test as well. So ideal thing is that both the couple has to be counseled together and the testing has to be done for both of them. And one more thing I would like to say, I think most of the things you have been covered, and if you acquired hemophilias, so genetic, I've seen many of them in hereditary hemophilia, so those are very rare, and they keep giving protein C, protein S testing and all. Those are so expensive, and it is not required. So please, in your practice, don't include all these tests, which are very rare possibility of hereditary hemophilias. Acquired, you can give, definitely you can give. That too after the pregnancy. I think you have covered that as well. After completing the pregnancy, at least 6 weeks of gap should be there. And single test, please don't take as positive. At least there should be 2 tests to be done with gap of, yes, So that has to be done. And then only you have to come into one conclusion. And most useless test, what I say, is torch. Because many of them I've seen, like in their practice, they give torch because once they are torch infected, and they definitely in subsequent pregnancies they develop the antibodies. So most unlikely these torch infections will have. And downs and all these are most unlikely. Balanced translocations in the parents couple, which will lead to the unbalanced translocations in the fetus. So karyotyping is ideal, but overall it is very good presentation.
Thank you, ma'am. Thank you, everyone.
Please be seated, madam. I would like to welcome next speaker, Dr. B. Radhika ma'am, Senior Consultant Gynecologist at Medicover Women and Child. Madam's patient-centric approach and clinical excellence is well known, and madam will be presenting an overview over current management strategies that aim to optimize outcomes for women with RP.
Thank you very much. Good evening, everybody. I thank Medicover organizers for giving me this opportunity. See, when I am treating a recurrent pregnancy loss, I feel like a backbencher. So who is the backbencher? Who partially listens to the teacher and does whatever they want. See, most of the recommendations, if you see, most of the recommendations are not indicated. So they say there is no evidence for the treatment. So let us go through the course, and you have to tell me at the last what are your things. So Dr. Savita has told us all the detailed etiological factors and pathogenesis of recurrent pregnancy loss. One important thing, what are the recommendations say? Some recommendations say 3 miscarriages, some say more than 3, some say 3 or more than 3, whatever may be. Contrary to what Dr. Anusha said, I encounter most of the patients where in the first pregnancy only they are very apprehensive, or when it comes to the second miscarriage, they are even more, entire family is more apprehensive. So on a practical note, what I does is, most of the first miscarriages may be sporadic. Whenever there is any second miscarriage is there, after the second miscarriage, sometimes or most of the times I do consider for investigating at least some of the things to rule out the recurrent pregnancy loss. So come to the non-modifiable factors. So the maternal age, ethnicity, or previous history of miscarriages or preterm births, they can't be modifiable. What can be modifiable? Lifestyle modifications can be done. Lifestyle modifications involves not only women, men also. This we have to emphasize when we are doing family counseling. So nowadays there is a new factor known as male factor which has come in the recurrent pregnancy loss. So lifestyle modification, either weight management or smoking, alcohol, stress, environmental factors, both has to be taken by both male and female partners. And decreased caffeine intake is supposed to decrease the miscarriages. Coming to the endocrine and metabolic disorders, these are all the endocrine metabolic disorders which I will be dealing one by one. So coming to the thyroid disorders, everyone will agree, whenever overt hypothyroidism is there, we treat with levothyroxine and we make optimal TSH, and here the benefit outweighs the risk. Coming to the subclinical hypothyroidism. In subclinical hypothyroidism, treatment may reduce the miscarriages. I am sure many of us also treat the subclinical hypothyroidism. And important thing is, you need to check repeated serum TSH levels during pregnancy. there comes gray area, where there is thyroid autoimmunity present, but euthyroid stage. Most of the IVF patients, they come to me, especially the international people, they come to me with the report where the euthyroid state is there, but their anti-TPO antibodies are high. Here in euthyroid, usually we do not treat with thyroxine, but we need to check the thyroid levels during pregnancy. But I do here, like a backbencher I told, I give immunoglobulins. I don't give immunoglobulins intravenously, but I give immunoglobulins intramuscularly, and I did not face any side effects to the medications which I have given. So I feel sometimes or most of the times it acts, and many of my IVF colleagues can correlate with this. So other endocrine disorders, luteal phase insufficiency. When you see the recommendation, either the progesterone or HCG, none of them will show evidence, or it is insufficient evidence is there. And ovulation induction in PCOS to get the good endometrium or to take care of luteal phase defects, also evidence is limited. And glucose metabolic defects, the metformin has insufficient evidence. Vitamin D, there is recommendation given for the vitamin D, where the vitamin D receptors are present in the endometrium. So correcting the vitamin D in preconceptual care, it is recommended. So luteal phase defects, as I told, there is insufficient evidence to prove the live births, but progesterone plays a major physiological role in the process of successful implantation and pregnancy development. So insufficient progesterone levels are associated with the pregnancy loss. I know all of us use progesterones for the miscarriages. Whatever are the recommendations are there, we use sometimes more than one, more than two also. But one good thing for us is the SRA guideline, where they recommend vaginal progesterones could be suggested for the management of a woman with a history of 3 or more recurrent miscarriages and vaginal bleeding. On a lighter note, whether it's more than 2 miscarriages or more than 3 miscarriages doesn't matter. And PCOS. There is no direct, it's not considered as a predictive factor for RPL, but obesity itself are related to PCOS, it can increase the miscarriages. Hyperprolactinemia. So the prolactin disorders are possibly associated with the PCOS or the luteal phase deficiency or stress or obesity, and we cannot make a direct link between the hyperprolactinemia and the recurrent pregnancy loss. Most of the times in a practical scenario, most of them will be having infertility, and where they will be treated before the conception for the prolactin. Coming to the uterine abnormalities. So what are the congenital uterine abnormalities which can cause recurrent pregnancy loss? So you can see there is high incidence of septate uterus followed by the bicornuate uterus and arcuate uterus. Coming to the aquoid uterine abnormalities, either submucosal fibroid or endometrial polyp or endometrial synechiae, they interfere with the process of implantation or embryo development and may result in miscarriage. And aquoid genetic pathologies. Yes, uterine leiomyomas and adenomyosis, these are nowadays we are seeing, and recent SRA guideline, it highlights the association of adenomyosis with pregnancy loss, and it recommends the evaluation. So coming to the management. So if you see the separate uterus, what is the recommendation? No benefit based on international or multicentric open label RCT. And for bicornuate uterus, metroplasty not recommended. For hemiuterus, uterine reconstruction not recommended. For didelphus, it is insufficient evidence. And for acquired disorders, either they are not recommended or insufficient evidence. See, if suppose in intracavity the polyp is there, leiomyoma is there, or some Asherman's is there, and you need to treat. If you don't treat, first of all, leave about the recurrent pregnancy loss. Pregnancy will not come. So whenever we see any intracavity lesion before evaluation, definitely we are going to do. And coming to the congenital abnormalities of uterus, yes, separate uterus is a common uterine abnormality, and correction of this may have beneficial effect and should be considered with RPL. So I think the primary limitation of these data is the lack of randomized controlled therapeutic trials. So as I said, if suppose the acquired uterine abnormalities are there, Asherman's, synechia or uterine fibroid, though there is no evidence, all of us will correct them. Coming to the cervical insufficiency. So in the cervical insufficiency, the actual groups that benefit the cerclage include 3 or more than 3 previous adverse events and short cervix of 2.5 cm or less with preterm birth. So what does the recommendation say? So whenever there is history of second trimester losses which are suggestive of cervical weakness, especially the history of the previous miscarriages is very important, whether they are painful or painless, whether heartbeat was there or not, whether there was rupture of membranes before or pain before, all these things will indicate us clinically whether really it is a cervical incompetence or not. So, in a singleton pregnancy with history of second trimester recurrent loss which is attributable to the cervical weakness, cerclage stitch should be considered. Nowadays, whenever these recurrent pregnancy losses are there, in the second trimester recurrent pregnancy loss, because of the cervical insufficiency, then we are doing an interval cerclage which is benefiting most of the patients. I think you all do agree for that. Coming to the infections. Yes. As Dr. Savita told, one important point in infection is infection may be a reason for sporadic miscarriage. It may not be a reason for the recurrent miscarriages, because if you have to attribute the infections to recurrent miscarriages, it has to be implicated in the etiology of repeat. It has to be there. The organism has to be capable of persisting in the genital tract and avoiding detection, and must cause insufficient symptoms to disturb the woman. Nowadays, the bacterial vaginosis which is present in the first trimester is leading to the second semester miscarriages. So, whenever you suspect any bacterial vaginosis, you need to treat the bacterial vaginosis so that to prevent the further miscarriages. Other important thing, most of the IVF people they are worried about is the chronic endometritis. Yes, it is characterized by the plasma cell infiltrate in the endometrium associated with a range of pathogenic organisms. And here antibiotics are found to remove the endometritis with apparent improvement in the live births. But this concept has not been tested in randomized control trials. So important thing in chronic endometritis is treating the chronic endometritis completely. is the key for the success. Once patient says, how many days I have to take antibiotic, and if you say longer time, they will not take. But emphasizing and then treating them completely is very important. Though some of the societies, especially the X-ray and SRM RSOG guidelines, do not yet recommend the endometrial biopsy, some other societies they consider the endometrial biopsy for women with RPL to rule out the chronic endometritis. Yes, dysbacteriosis. Nowadays, this is a new recent concept. The endometrial cavity microbiome is considered as important predictor for success in pregnancy. Any dysbacteriosis in the female reproductive tract is associated with the recurrent miscarriages and should be treated as a novel risk factor. So when you see most of the IVF people's consultation paper, you see the probiotics also. Coming to the genetic factors. So in the genetic factors, there are two important things. One is the testing of the POC, and second one is the testing of the parents. So these two are very important. So as I said, if suppose sometimes we may not be there, we may not wait till, or most of the patients they don't wait till 3 or 4 miscarriages. Sometimes we may have to do the testing before only. And one more important thing, just when I am discussing with my IVF colleague Dr. Runa, I came to know that if any patient who is not ready to do the POC testing at the 2nd or 3rd miscarriages because of any financial constraints, they can store the DNA. So that there are labs which can store the DNA so that if it is necessary, they can go back. If suppose further any miscarriage happening, they can go back and test for the previous miscarriage reason. So this is very good point, Dr. Runa. Thank you very much. Till now I did not know about that point. So whenever the POC microarray is done, whether it is aneuploid or euploid, or if there are any structural rearrangements are there, this is how the treatment goes. So if suppose the POC is showing euploid, then you have to rule out other reasons for the recurrent pregnancy loss. And if suppose there are structural rearrangements, definitely you have to do the parental karyotyping. So whenever any parents, they have there is problem in the karyotyping or the further test, genetic counseling is required, and depending upon what are the reports, depending upon what report says, that further treatment will be there. If it is a genetic disorder where they can do PGT, then they can mostly in IVF along with the PGT, they can avoid the particular disorder. If suppose it is very lethal, then they have to go for the gamete donation or for the adoption. So thrombophilias, either hereditary or acquired. So what are the guidelines says? X-ray or SRM do not recommend the routine screening associated with the thrombophilia and RPL. Only women with previous thromboembolism or a history of miscarriage should be tested for the inherited thrombophilia. As Dr. Anusha has told, so this is the point and for the recommendation. And there is no need to monitor the plasma coagulation markers during pregnancy. Coming to the antiphospholipid syndrome, all the societies unanimously agree for the treatment of APS in the recurrent pregnancy loss. They agree for the aspirin, they agree for the heparin. So they unanimously recommend combined therapy with the low-dose aspirin and also either heparin or low molecular weight heparin. We are using low molecular weight heparin because of its long activity, and also there is decreased incidence of osteoporosis and also decreased incidence of thrombocytopenia with the low molecular weight. Only one important thing, when you should start anticoagulation therapy. So it is usually started when there is positive pregnancy test is there. The second point is very important. The patients with APS treated with low-dose aspirin and low molecular weight heparin should continue the therapy during the postpartum period to ensure the reduction of thrombotic event risk. This, as an obstetrician, we have to emphasize. Most of the times, once the baby is born, patients will be roaming around the pediatrician and neonatologist. They will not come to the obstetrician. So, whenever they are inpatient, then we have to emphasize these problems. And RCOG guidelines does not suggest the use of corticosteroids or the intravenous immunoglobulin for therapy for managing APS in RPL patients. But yesterday suggested the administration of repeated and high dose of IVIG very early in pregnancy that could be beneficial for the thrombophilias. What is the treatment? So main treatment is the antithrombotic only, and there is no benefit for the low molecular weight heparin for prevention of pregnancy loss. Coming to the acquired, we start low dose aspirin starting before conception, and we give prophylactic dose of heparin after positive pregnancy test. Coming to the male factor. So this is a new factor which has come into the recurrent pregnancy loss. HRA recommends the evaluation of sperm DNA fragmentation in couples with recurrent miscarriages should be considered. So what is the treatment for the male factor? As you said, not only women, most of the times we will be counseling women, counsel the husband also. So he also has to make the lifestyle changes, and there is no role for ICSI. Antioxidants, the recommendation is does not increase the live birth rate, but I don't feel any harm in giving antioxidants. And IVF people can do somewhat justice to these patients. So, a recent systematic review and meta-analysis reported that DNA fragmentation was indeed significantly associated with miscarriage, and the results conclude that using methods to select sperm without DNA damage may reduce miscarriages in assisted conception treatments. More than 50% of RPL is unexplained. What to do in this? So coming to the vaginal progesterone. It may improve live birth rate in pregnancy for 3 or more than 3 pregnancy losses and vaginal bleeding, and even oral dydrogesterone after fetal action is seen may be effective. So most of us use, and there is immunomodulatory effect of dydrogesterone. High dose of intravenous immunoglobulin, the recommendations are, may improve live birth rates in women with 4 or more than 4 unexplained RPL. The dosage is 400 mg per kg for 5 consecutive days in very early in pregnancy. I don't give IV intravenous immunoglobulin, but I do give intramuscular immunoglobulin. I did not face any of the side effects for that one, and cost is also economical. Coming to the lymphocyte immunization therapy, it should not be used, may be used only for certain ethnic people, and sometimes it may have serious adverse effects. And glucosteroids, they are not recommended for the unexplained RPL. Intralipid, insufficient evidence. GCSF, no evidence. For some of the cases, I have given GCCF, filgrastim. Mostly the complications are not there. Sometimes there can be little mucositis and bone pain can be there. But nowadays, I am avoiding, I will see how the pregnancies will progress. Especially for the medico-legal cases, I am avoiding that. And for RPL, heparin or low-dose aspirin is not recommended. And IVF plus PGT is insufficient evidence. Endometrial scratch, most of the IVF people do. There is no evidence to recommend. And low-dose folic acid, it is for the prevention of neural tube defects rather than for RPL. So what are the novel agents under trial? If you see, some of the IVF people or some of the gynecologists are using one agent known as thymosin alpha. What is this thymosin alpha? So especially, main important thing is in any recurrent pregnancy loss or implantation failure is the immunological milieu in the endometrium, where the T2 helper cells should be more, T1 should be less, and NK cells should be low. So all these immunomodulators, whatever you use, or especially if you send it to the rheumatologist, they'll start the patient on HCQS, and all these things are the immunomodulators. Like that, thymosin alpha, it is immune-related or unexplained recurrent pregnancy losses. It's often used in patients with abnormal NK cell activity, and the dosage is 1.6 milligrams subcutaneously, twice in weekly. And treatment timeline 4 to 6 weeks before conception or embryo transfer, continue until 10 to 12 weeks of gestation. It can be extension up to 16 weeks based on the immune profile. It can also be used with the other medications. Monitoring is by the immune markers and it's off-label. I have not yet used this agent. First important thing what we do is the psychological counseling. That's very important. So tender loving care, only limited evidence, but it itself improves the pregnancy outcome. This is the point why the patient should come to you. Once you come, then only you can treat. Okay. Even if not, it is hard to argue against this approach. So coming to the summary, genetic defects, genetic counseling, and depending upon what is the problem, then going for the PGT. Second thing is, unanimously we accept for the aspirin and low molecular weight heparin. Uterine anomaly, though there is insufficient evidence, we all do intracavitary lesion excisions and the separate uterus correction. Cervical insufficiency, when cervical length is less, we can't take a risk, we will go for circlage. Thyroid problems, yes, for overt hypothyroidism, we treat. For subclinical hypothyroidism, we are treating. When euthyroid with autoimmunity, it is a grey area. And sperm DNA fragmentation, lifestyle changes, recommend antioxidants are no role. And ANA positive, no specific treatment. And in unexplained, the vaginal progesterones, IV immunoglobulins, it has a role, but there is no role of lymphocyte immunotherapy, steroid or intralipid or GCSF, aspirin, high-dose folic acid or scratching. So this is a patient, after septum resection she has conceived. This is a patient I treated for the Apla syndrome. Advanced happy Mother's Day to all of you. Thank you so much.
Nice and elaborative talk, madam. I think most of the points have been covered. And again, I want to tell the audience little generous to the patient. And I've seen many of them giving cocktail regimens. So they start with luteal phase, progesterone support, followed by ecosprin, heparin, whatever it is. Without evidence of diagnosis, please don't treat. And one more thing, when madam was telling, recently I've seen people suggesting endometrial biopsy as well. So endometrial Pipperly biopsy to rule out endometritis and maybe the prolonged antibiotic usage also can prevent miscarriages where unexplained miscarriages are happening. And one more thing, and you were telling madam that patient consult us when we send for testing. So we should make sure that it should not have maternal contamination. I mean maternal blood and all. So sometimes when they pass the, they should keep it in sterile. How to send to the testing, that is also important. These are the basic things. Many of times it's been missed and reports doesn't come normal. And pre-gamete testing. So that is also, I think, makes us take us long way. And if they have especially unbalanced translocations, so pre-gamete testing also is might be very useful for them to conceive immediately. So only if they go for good embryo transfer, I think that can solve their problem rather suffering for recurrent 6 to 7 miscarriages.
I read one point about this endometrial scratching because some of the IVF specialists do, and what they have given in the thing is, if suppose NK cell activity, whether overactivity or underactivity, any of the thing can cause miscarriage, but in that book they were recommending endometrial scratching if NK cell activity is low. So I don't have any practical approach to this. My IVF specialist can correct me if it is wrong.
Thank you, madam.
Thank you so much.
Thank you for the medical work for giving me this opportunity. Thank you.
Thank you, Dr. Radhika ma'am, Dr. Savita ma'am, for enlightening presentations on recurrent pregnancy loss. I also thank you to Dr. Anusha madam for expertly moderating the session. I now request Dr. Venkat, Medical Superintendent, to please hand over the mementos to Dr. Radhika, Dr. Anusha and Dr. Savita. Session on NICU care, neonatal outcomes and safe neonatal transport, giving newborns the best possible start. We are pleased to welcome Dr. Ramsey Reddy, Head of Department of Pediatrics and Neonatology in Medicover Women and Child Hospital, to share his valuable experience and practical insights on this important topic. Moderating this session is Dr. Janardhan Reddy, a Senior Consultant Pediatrician and Intensivist with extensive expertise in neonatal care, who will guide us through this engaging and informative discussion.
Good evening all. So far the entire afternoon we have been listening to experts speaking on obstetrics, high-risk pregnancies. Now we will look at the other end of the pregnancy. When my Medicover scientific team asked me, Doctor, can we do a topic on NICU care, NICU outcomes and neonatal transport? I thought about it for a couple of days and I agreed to do this presentation. We all know NICU is a special place with specialized and life-saving support provided to the newborns who require intensive medical attention soon after birth. NICU plays a critical role in the survival and development of premature and critically ill babies. NICU contains incubators, ventilators, monitors, which can help us regulate temperature, support breathing, and track vital signs. It involves multiple teams, which includes neonatologists, neonatal nurses, dietitians, admin team, to collaborate and to provide holistic care. It's mainly a family-centered approach. Parents are encouraged to participate in the care, including kangaroo, which supports bonding and infant stability. We look after the nutrition. It is vital for growth and healing. We often use mother's own milk, sometimes donor's milk, in some instances special preterm formula, TPN in newborns who are extremely preterm, and we also take dietitians' help who can tailor-made feeding according to the baby's need. We use development supportive care to promote brain and sensory development, minimizing noise and bright light. We always take care, the lights in NICU are not too bright and noise is not too loud. We look after how to position the baby, which should mimic the position in the womb, and we are very gentle to touch. When the babies spend in NICU, sometimes it can be weeks, months, sometimes 3 months, who are extremely preterm babies who spend 2 to 3 months in NICU. And all preterm babies who go home, before going home and before going home and getting discharged, we send them to rooms that we call it as rooming in. They spend many days in the rooms along with the parents or extended family who learn feeding the babies. We teach them how to feed the babies, and we also give sessions on CPR so that in case if any rare event happens at home, so that parents are equipped to deal with such emergencies. We send them home with little mask and ambu bag, and we train them basic life support. We also train them how to administer medications, and we coordinate the follow-ups. We don't leave them after going home. We call them at regular intervals, and we also monitor them on the phone as soon as they go home, and next day we phone them and check whether everything is okay. Long-term outcomes and follow-up. Many NICU graduates grow up healthy with not of major problems, but sometimes we face challenges like developmental delays, problems with vision and hearing, chronic lung disease, or cerebral palsy. We typically offer follow-up appointments. At Medicover, we normally look at preterm babies mainly on Wednesdays to track their growth and development. It comes with challenges. Babies being in NICU is emotionally challenging for families. Stays are often unexpected and traumatic for the families. Parents may experience anxiety, depression, and post-traumatic stress disorders. Hospitals often provide counseling and educational resources to help parents cope and actively participate in their baby's recovery journey. NICU is not just a place of medical care. It's a bridge of hope for vulnerable newborns and their families. Through technological advances and compassionate care, many babies once thought unlikely to survive are now thriving. What do we do at Medicover? We have 25-bed NICU, awarded as level 3 unit recently by National Neonatology Forum. We have high-end infrastructure, high-frequency ventilation, conventional ventilation, inhaled nitric oxide. We have a strong neonatal and pediatric team, which includes pediatric surgeon. We have a strong OBG team. They look after high-risk pregnancies very well. They hand over babies in a good conditions. Hence, we are able to look after them properly, and our outcomes are good. We have a good anesthesia team, good radiology team, which supports us all the time. Again, the supportive admin team, without their help, it's not possible for us to look after tiny babies. Flexible financial flexibility is there for the families. We have sources from charity as well. We have fellowship training program. We have 2 fellows every year recognized by NNF India, and we have 24/7 transport services at Medicover Women and Child Hospitals, Madhapur, High-Tech City. Now the next topic in my presentation is neonatal outcomes. Good neonatal outcomes generally refer to a positive experience for newborns, including successful transitions to life outside the womb, with minimal or no complications and a healthy development. These outcomes are associated with improved survival rates and fewer long-term health issues. What are the key factors for good neonatal outcomes? First is optimal gestational age. Infants born at or near term, that is 37 to 41 weeks, have significantly higher chance of good health and development compared to those born prematurely or post-term. Next key factor is appropriate birth weight. As we all know, infants born with appropriate birth weight tend to have fewer complications and those who are born with small weight. Effective antenatal care, proper prenatal care including regular checkups, vaccinations, and addressing potential risk is crucial for a healthy pregnancy and subsequently a healthy newborn. Safe delivery practices is another important key factor which can help us in giving good neonatal outcomes, minimizing complications during labor and delivery, such as preventing asphyxia or birth trauma, which can significantly impact the neonatal outcomes. Early and adequate neonatal care, prompt and appropriate neonatal care including resuscitation, feeding, temperature regulation, and monitoring for complications is essential for survival and well-being of babies. And we also follow golden hour. We tend to do all the procedures when we come across a preterm delivery. We will be very quick in moving out the baby from delivery room or the theatre, maintaining the temperature. We look after the initial basics in theatre or labor ward, move them to NICU, try to do the procedures within first 1 hour, like getting the umbilical lines, getting the IV cannula, or giving antibiotics, giving caffeine, whatever, even including the X-ray. We try to do within 1 hour. That helps in long-term survival, that helps in good outcomes. Parental support and education is also an important factor which helps in good neonatal outcomes. Providing parents information about the baby's care in an ICU, and breastfeeding is another important contributing factor which helps us in giving good neonatal outcomes. KMC, this practice is good, which helps in bonding between the mother and baby, and especially in preterm babies. It has been shown to improve temperature regulation, and overall well-being is good when we practice KMC. Effective management of preterm births. like careful monitoring, administration of antenatal steroids to promote lung development, early intervention for respiratory distress syndrome, early identification of infections like prompt diagnosis and treatment of neonatal infections and other infections can prevent serious problems and which can improve the survival. Breastfeeding, we all know that it provides essential nutrients and antibodies that protects newborns from infections and it promotes healthy growth. Developmental care, providing nurturing and stimulating environment for newborns, including appropriate handling, positioning, sensory stimulation can support their development. We encourage nurses to attend development care sessions at regular intervals in and around Hyderabad, and we help them to go and attend sessions, and we practice the same in our NICU. There are quite a few parameters where we can measure the outcomes in preterm babies or term babies. These parameters I got it from UK. I was there in UK for 14 years. Every year we do audits on these parameters and reflect on where we need to improve our care, and we re-audit and see whether we have reflected on our practice or not. This audit in UK is called as National Neonatal Audit Program. We look at all these parameters and reflect on the practice. What are the parameters? Antenatal steroids. How many mothers are receiving antenatal steroids? Deferred cord clamping. Whether every baby is going through the delayed cord clamping wherever it is indicated. Antenatal magnesium sulfate, which helps in neuroprotection. Whether all babies born in NICU with appropriate facilities. What is the temperature on admission? Less than 36.5 is not good for babies. Breast milk in term babies and in preterm babies, whether we have started the babies on breast milk in the first 2 days of life. Audit is also based on mortality, how many babies die, how many babies develop bronchopulmonary dysplasia, how many babies develop necrotizing enterocolitis, bloodstream infections, IVH, complications of IVH, cystic periventricular leukomalacia, and retinopathy of prematurity, whether all babies are getting screened for ROP as per the recommendations. And there are other parameters. We look at breastfeeding at 14 days of life, how many babies are on breast milk at 14 days of life, breastfeeding at discharge, whether parents getting update or got the update soon after a baby got admission into NICU. It's better to talk to the families sooner rather than waiting, make them wait for many hours to get the first update. In summary, good neonatal outcomes are the result of combination of factors including optimal gestational age, appropriate birth weight, effective prenatal and effective neonatal care, supportive parenting practices. I thought I should take this opportunity to display our outcomes at Medical Women and Child Hospital, what we went through in 2024. It's 3-4 slides I'm going through and finish the session on outcomes, then I'll talk on neonatal transport. Total, there were 349 admissions in 2024. Baby boys 189, baby girls 160. If you look at the gestational age, there were 21 babies less than 28 weeks of gestation. Between 28 to 32, there were 33 babies. 32 to 36 weeks, there were 155, and more than 37 weeks, there were 140 babies. So the numbers marked in red, around 53, close to 15% of our NICU work is babies who are born less than 32 weeks of gestation. Out of 349, sadly we lost 3 babies. These 349 babies included the neonatal pediatric babies with neonatal pediatric surgical problems as well. There were few babies who needed correction after congenital malformations, babies with urological problems, urogenital problems, 2 babies with intestinal obstructions, a baby with spontaneous intestinal perforation, couple of babies with malrotation and valvulus, and many more. If you look at our sepsis in our unit, serious sepsis, serious infections are negligible here. The CRP positive was in 29 babies, blood culture was positive in 1, urine culture was positive in 7. Normally we do urine culture in babies who are jaundiced, term babies who are jaundiced after 14 days of life, and preterm babies who are jaundiced after 21 days of life. We do, as a part of our guideline, we do urine culture, and there were 7 babies with positive urine culture. CSF positive meningitis was positive in 2 babies, 11 babies had pneumonia, clinical sepsis, blood culture negative, CRP negative in 2 babies, VAP none, central infection associated infection none, neck we came across 1 baby, antibiotics for more than 5 days. There were a total 13 babies in 349 who needed antibiotics for more than 5 days. If you look at the morbidity, there were 5 babies with seizures, 2 babies born in poor condition, 1 baby needed cooling, 1 baby had Erb's palsy, 1 baby with IVH, intraventricular hemorrhage, and ROP assessment was done at regular intervals. No baby required any treatment in that aspect. Bronchopulmonary dysplasia in 4 babies. Babies requiring mechanical ventilation more than 48 hours, there were 8. So I can proudly say our outcomes at NICU, at Mother and Child, Medicover Women and Child Hospital at Madhapur, our outcomes are good. It's one of the best centers in Hyderabad with negligible serious infections. And the last topic for this session, neonatal transport. All neonatal transport guidelines must ensure safe and effective transfer of newborns requiring special care. We need to emphasize the pre-transport stabilization. When we go and to retrieve the babies, we should make sure babies are stable enough to transfer. We should carry appropriate equipment, and we should have appropriate equipment for ongoing monitoring during the journey. What are the key aspects? Maintaining a stable airway during the transfer, managing the temperature for the preterm baby or term baby, ensuring adequate oxygenation, providing adequate support for feeding and fluid balance. Communication is very important. Communicating with the receiving hospital to confirm availability of resources and to share the neonatal condition. Like for us, we go out and transfer big babies, so the doctor who is gone and assess the baby. We get a call from that doctor, and we receive the information, and on the phone we advise them from the base hospital what to do if the baby is not stable to transfer. So we first stabilize the baby and we start the baby moving into the ambulance. Documentation is very important, and of course parents counseling with families and parents. First we need to tell them the baby's condition, where we are going and what happens after that. I'm sure that every neonatal transport hospital with neonatal transport services will have this neonatal transport incubator. We should use this for preterm babies, otherwise maintaining the temperature is very difficult. Sometimes for term babies we use that bag which is helpful, which is handy, so that we can keep the baby warm inside that insulated carrier. During the transport, we should provide adequate oxygen support. Monitoring, we should have the monitoring system and system to adjust the FiO2 as and when required. We should continuously monitor vital signs such as heart rate, respiratory rate, oxygen saturations and temperature. We should provide appropriate fluids to maintain hydration, and we should also monitor the blood sugars. This is our main vehicle. With transport incubator facility and transport ventilator facility, we use this vehicle all the time. We have a dedicated transport team 24/7 at Medical Women and Child Hospital, and we have tie-ups with various hospitals in and around Hyderabad, and we also travel more than 200 kilometers and bring the babies into our NICU. Thank you all.
Good evening all. It was a nice, excellent and brief overview about NICU care and multidisciplinary treatment of team approach and aseptic precautions and family-centered approach. And again, we have touched upon transport also. So, one thing I observed is our NICU teamwork or outcome is on par with any international NICU units. So what practices helps us to get that outcome?
Thank you, Janardhan.
Yes. Compare with IVH or NEC or sepsis. Only one case we have IVH, and almost 1/3 of the babies are premature babies, so less than 28.
Correct. Yes, you are right. Our outcomes are, as I said, I worked in NHS hospitals in UK for 14 years. You are right, our outcomes are, we can match with UK standards in medical hospital. The reasons maybe the multifactorial, starting from the obstetric team. As I mentioned before, they will look after high-risk pregnant ladies very well, and they give us babies in a good shape. Probably the good outcome starts there, and I'm sure the antenatal steroids helps, magnesium sulfate in time helps. Our NICU, we look after birth, starting from looking after the temperature. We keep them in plastic bags straight away as soon as we receive the babies. So starting from that point, giving surfactant to whoever is needing surfactant, sooner the surfactant, better the outcomes. Move them out as soon as possible from theatre so that we can switch on the ACs back so that obstetricians will be happy. Then moving to NICU, coming to NICU, doing the procedure, strict hand hygiene, strict asepsis, nurses, good nursing team, good neonatal team. Without nurses, it's very hard to manage NICU. We should have a good nursing team. Probably we have a good nursing team for our setup. We don't disturb the babies a lot. and let me put it this way, we don't trouble the babies a lot. We keep them quiet so that their blood pressures are quiet, blood pressures are stable, so that they don't develop IVH. Though we have good OBG team who give us babies in a good shape, but after that is very important. We should not trouble them. We should not poke them. We should not disturb them. So first 3 days is very crucial for babies. 90% of IVH happens in first 3 days. So we should look after those first 3 days very well. After that, that's a good news for babies. And strict hand hygiene. Still we practice mask in our NICU. Still, though COVID has gone long way back, but we still practice mask, strict. We wear gown, we wash hands between each babies before we examine. Hence, I think that's why our infection rates are very less.
Even our duration of antibiotic course is less than 5 days in extreme premature babies also.
Correct.
That is one excellent and wonderful thing what we are doing good for the babies.
I don't want to jinx it, but we have a 23-weeker now who is 3 weeks old, had 48 hours of antibiotics. Because baby was born in good, there were no risk factor for sepsis, 48 hours of antibiotics, 3 weeks old, baby is 435 grams. Baby is on CPAP.
One more question, sir. Many of them here are practicing gynecologists, obstetricians. So when we can advise them in utero transfer is better than delivery at their own nursing homes or practicing where there is no lack of an neonatal team or an NICU facility.
Yes, it's a good question, Janardhan. It's obstetricians. We have many obstetric colleagues with tie-ups with different hospitals. We go and help attend deliveries or bring babies. I thinking in the perspective of obstetricians, they are very comfortable in their own hospital to deliver, to do sections. But when it comes to extreme preterm deliveries, if there is no option, we go there and help, it's okay. But if there is an option, it's always good to move them into the NICU with tertiary level services, especially extreme preterm babies. Transport is not always safe. It's a challenging task to keep the airway patent. It's a challenging task to maintain the temperature. Sometimes babies' ET tube can come out. It's very rare scenarios, but if there is a chance, it's always good to deliver the babies, especially high risk and extreme preterms, in a center where we have level 3 NICU services.
We can maintain normothermia and even risk of IVH also will come.
Yes. Recently, for example, there was a baby 6-7 months ago. We were called to retrieve a baby in one of the hospitals in Hyderabad, to retrieve a baby who developed pneumothorax. All respect to the referring team, they did whatever they could, but we had to go there because baby developed pneumothorax. There was little resistance when we want to put the chest drain in the peripheral hospital. They wanted us to take the baby as it is so that we can look after that baby in our NICU here. But pneumothorax is like a bomb under the pillow. We should have the chest drain in situ and move the baby. Hence, our senior consultant went to the site, did the chest drain, brought the baby safe, and we discharged the baby safe.
Okay, sir. Thank you.
Thank you. Thank you.
Thank you, Dr. Ravindra Reddy, for your insightful session. Your practical approach and depth of experience has added great value as reflected in our NICU. A heartfelt thanks to Dr. Janardhan Reddy for skillfully moderating the discussion. Also, I thank Dr. Navita ma'am for enriching the session with your neonatal expertise. I now request Dr. Venkat, our medical superintendent, to present the mementos to Dr. Ravindra Reddy and Dr. Janardhan Reddy and Dr. Navita ma'am.
60.
Tina this one.
On an evolving field in obstetric care, fetal therapy. As technology and techniques are advancing, the horizons for fetal interventions continue to expand. I am pleased to welcome Dr. Amita Indersingh ma'am, fetal medicine consultant, an expert in fetal therapy, who will share her insights on the latest development in this exciting area of medicine. And moderating this session, I request Dr. Varalakshmi ma'am and Dr. Meenakshi ma'am to join us on the stage.
Good evening, everybody. I thank the team from Medicover for inviting me to talk on this topic. And fetal therapy, yes, it is something that we are already doing in some form or the other. But now things are evolving and things are moving into the next realm where we are really pushing the horizons. We are trying to, push the chances of survival and trying to improve the chances of outcome for many babies who would not otherwise see the light of day. So going directly into my talk, so when we are talking about fetal therapy, what are we trying to do? Basically, we are trying to prevent the baby from dying. We don't want the baby to have a demise in utero. But more importantly, we want the baby to survive and thrive. So we want the baby, the morbidity to be reduced so that it can be managed and treated after the birth of the baby. Now, when we are doing a procedure, we are basically trying to convert a fatal or a lethal disease, trying to make it better, and we are trying to do this based on various randomized controlled trials and improve the chances of survival. So whatever we do in the name of fetal therapy, it is important that it has a sound backing, and fetal therapy has to be conveyed, or the therapy has to be transmitted to the baby. It can be through the mother itself, or it can be directly to the fetus in the womb. So now, through the mother, it is via the placenta, so it can be transplacental, or we try to access the baby directly. I'm going to talk about transplacental first, because this is something which we have been doing for quite some time. It's just that we haven't called it fetal therapy. So we had a patient who had a cardiac arrhythmia. So we can see on the screen there that the baby had an atrial rate of around 462 beats, whereas the ventricular rate was around 232, practically half. So there was cardiac arrhythmia, which we decided to treat. So the baby who was presenting with atrial arrhythmia, we decided to do a medical treatment. Now this treatment is going to be administered to the mother. So when we are administering things like that, we make sure that the mother is safe. So the maternal assessment and monitoring is done.
and the baby was treated with medication. We started her on sotalol, and we started with 400 milligram and increased it, and it took a few days for the heart rate to stabilize. So this is in 2 days. We can see that the heart rate, the atrial and ventricle is 125 and 123 beats. So the block is gone as well as the heart rate has normalized. So this was medication administered to the mother to treat the baby. Same baby at 37 weeks with a stable heart rate was delivered by elective LSCS at term with a normal birth weight, and baby had a normal sinus rhythm. So this was a treatment which helped the baby to be born where it did not require further treatment, and this baby thrived well and did not have any issues so far. Right now the baby is around 3 years old. This is another case of congenital adrenal hyperplasia. The mother had already lost 2 full-term babies. They were born with query-ambiguous genitalia, and the previous pregnancy was diagnosed as congenital adrenal hyperplasia, and the risk of recurrence was explained. Still, once she got pregnant, she came to us somewhere around 16 weeks. So we started her on dexamethasone from early pregnancy onwards, and she went on to deliver at 36 weeks. Now this treatment that we are giving is more to ameliorate the condition. It is not going to correct the adrenal hyperplasia, because adrenal hyperplasia is a genetic problem which we are not going to correct with medications. Here we were trying to prevent the virilization from happening, and we were trying to optimize the conditions until delivery, after which medical management could be started. So this baby did well. This was another case of where the patient came to us for a normal TIFA scan, anomaly scan, where we found there was massive ascites. So you can see the liver here surrounded by fluid all around. That is the image of the bowel with again fluid all around. And the reason for all of this happening was that is a section of the chest where you can see that bright mass in the chest, which is causing a mediastinal compression. And because of this compression, the baby was going in for hydropic changes. So that's the lung, echogenic lung. So that was congenital pulmonary airway malformation causing hydrops. Now this becomes an emergency, because if this baby is not taken care of, it is going to go in for fetal demise very soon. So she was started on injection betamethasone, and this is very similar to the dose we use in our antenatal prophylaxis. And we use this only in conditions, in situations of CPAM where we feel that there is a need for intervention. So you can see that as the baby went through pregnancy from 24 weeks to 26 weeks, the ratio or the size of the echogenic lung compared to the thoracic circumference is becoming relatively smaller and smaller. But most importantly, there was no hydrops. The ascites resolved and the baby went on to deliver normally, and the CPAM was managed postnatally, and the baby did well. So here I've just listed a few of these scenarios where we do transplacental therapy. I've said we've been doing it in some form or the other. I'm sure all of you are using antenatal steroid prophylaxis. So that itself is a form of fetal therapy. Now moving on to directly accessing the fetus in the womb to give it some kind of treatment. When we are trying to give fetal therapy, it can be through various techniques. So it can be a percutaneous needle-based therapy, or we use a fetoscope, or a step further is we try to do a hysterotomy, exteriorize the fetus, do whatever surgical procedure we want to do, or there is an option of ex utero intrapartum therapy in a few scenarios. So when we are talking about percutaneous needle-based, through the needle we are delivering some form of treatment. Now through a needle we can give the baby blood as we do in an intrauterine transfusion. We can give the baby a medication, a drug. We will, for example, like how we talked about arrhythmia, we can probably give the baby digoxin in some emergency scenarios. We can deliver forms of energy like radiofrequency ablation, or we can put in a device like a shunt, or some fluid therapy we don't really do. We remove fluid sometimes, which is similarly like we do a thoracocentesis or a pericardiocentesis sometimes. So any kind of fetal procedure is very important that we have the family and patient on board 200%. Because one, it is a procedure which has an inherent risk of miscarriage or loss of the pregnancy, and the patient and attenders need to understand what we are trying to do. Most of the time, as I said, we are not curing the condition, we are making it better. Now, most of our patients think that once they have paid, they have undergone a surgical procedure, they want guarantees that it is not going to come back, that it's not going to, affect the baby hereafter. They need to understand that that is not what we are doing. We are trying to make things better for the baby so that it can be treated and be handled after the delivery. And for this, we need the entire multidisciplinary team of the fetal medicine, the obstetrician, the neonatologist, and the pediatric subspecialties to be on the same page. So we do need probably a combined counseling which will really make a difference. This is the pre-op workflow, which I don't think we will go into right now. So this is the most common fetal therapy which we encounter or which we are doing. So when a baby is anemic, the anemia can be due to numerous causes. The most common one we encounter is due to RH sensitization. Now when the baby is anemic, what we are trying to do is basically give the baby very highly double-packed blood transfusion, so that we are giving the baby RBCs, we are correcting the anemia, trying to buy time. Here, what we are trying to do is preventing the baby dying of cardiac failure due to anemia. So we are buying time, trying to get the baby to reach term, deliver the baby, after which the maternal antibodies are not going to be attacking the fetal blood, and the baby has a good outcome. So when there is fetal anemia, which we monitor by looking at the MCA or the middle cerebral artery peak systolic velocity, we interpret it in terms of moms, and when it crosses the critical value of 1.5, we contemplate doing a blood transfusion. Now, this blood transfusion that we give to the baby, the blood is always O negative, it is double packed, it is leukocyte depleted, so it is irradiated blood, so that it does not interfere or cause problems with the already existing blood of the baby. And the transfusion, as you can see here, it is not done in some fancy setup, not in the theatre, it is just done in an ultrasound room. It is done under only local anesthesia, so doesn't really require a lot of facility or a lot of equipment. So you can see my tray there also is hardly anything, lot of needles and syringes, but that's about it. And when we are going to give the blood transfusion, we want to deliver the blood into the circulation of the baby. So we have various access points. It can be directly into the umbilical vein. Here we have an anterior placenta and a posterior placenta. That's the needle. We are going into the umbilical vein, positioning our needle. And here you can see the needle has already been positioned. You see that little streaming happening. That is basically the blood flowing into the umbilical vein. So this is one of the easy ways of accessing the fetal circulation. The other way of doing it is directly into the portal sinus. Each of these have their own advantages, and all of them have the same outcomes of the risk profile. So here again, the needle tip is inside the portal vein, and you can see the streaming of the blood flow into the fetal circulation. You have the aorta on the distant side there. That is how we monitor the heartbeat to see if there's any bradycardia developing, so that there's no cardiac overload as the blood is being transfused. So once we have given the transfusion, as I said, we are buying time. But it is important that we know that one transfusion might not always be sufficient. Baby might require a repeat transfusion. For example, if we do a transfusion somewhere around 24 weeks, the baby will probably around 26 or 28 weeks require a repeat transfusion. How do we time this transfusion? The MCA is not reliable once you've given a transfusion, so you cannot use it. You cannot wait for the baby to become hydropic again. So we usually use a formula to calculate based on the final hematocrit that was achieved in the previous transfusion. And we try to buy time until around 34-35 weeks. I'm sure sir will be happy even if it's 32 weeks. So basically get the baby to a reasonable gestational age, deliver the baby in a facility where there is a good NICU backup, basically because the baby is going to have very bad jaundice. The excess blood that we have transfused is going to be breaking down. As long as the baby is inside, the placenta is taking care of the bilirubin. But after the baby is born, there is going to be bad jaundice. And once we have transfused blood, the baby's hematopoietic system might be in suppression. So the baby might have a drop in the blood counts, the baby might have an anemia after delivery, which will require top-up transfusions, and then the baby rebounds. So it is important that you have a good NICU backup and who are aware of these things. The other next one we are going to talk about is drug. Now this was a giant chorioangioma. Now chorioangioma is something that behaves like an AV malformation. It's basically also stealing circulation from the fetus. If the chorioangioma is big enough, it can cause hydrops and cardiac overload of the baby also. So here we see this big mass with a big vessel right in the center. So we had to do something about this because the chorioangioma was growing very rapidly. So here we decided to do a occlusion of the vessel using polymer. We use butyl ester polymer. So once this polymer is injected, the moment it touches the blood, it polymerizes. So when you inject this polymer into the vessel that I showed you, it polymerizes and occludes the vessel. And because of the rapid polymerization, it does not travel distally in the vessel. It occludes the vessel very close to the point of injection. And then the tumor growth is stopped because of lack of vascularity. So that is, you can see the needle coming in from on top. And here you can see we are just injecting a little bit of 5D to make sure that it is flowing well. That in the other screen, you can see it when we are injecting. Very quickly it forms that thread like the polymer which occludes the vessel practically in seconds. The next modality is using energy. Here we are going to talk about radiofrequency ablation. Radiofrequency ablation can be used for a lot of indications. So we had a case where we did it for a case of selective fetal growth restriction in a monochorionic twin. In monochorionic twin, the problem is if we have to do a reduction of one twin, if we inject anything into the circulation of one twin, it is going to travel to the other twin through the placental anastomosis. So we cannot do the routine kind of fetal reduction. If one baby dies, if the smaller baby which is having unstable Dopplers dies, there is going to be hemodynamic instability and the normal healthy baby is going to exsanguinate into the dying baby, and the baby which is bigger is going to have ischemic damage. So this is basically what we are trying to prevent. When we do a radiofrequency ablation, we are basically closing off the circulation or supply to the smaller baby. So we are losing one baby. It is a form of fetal reduction, but it is trying to save at least one baby, where if untreated we would lose both. So this was a patient, this was not a TT case, this was a radiofrequency ablation. There you can see the radiofrequency needle. It has tines which open up once you inject it. So that's the radiofrequency needle. So you can see the needle there. It is placed at the point of insertion of the umbilical artery and vein, the cord insertion, and then the tines are opened up and we use the radiofrequency energy is applied. So once the energy is applied and the coagulation happens, you can see those little bubbles arising as the tissue is undergoing coagulation. Post procedure, there is no circulation or no vascularity seen in the umbilical cord. So indicating that the procedure has been successful in closing off the supply. The same thing, radiofrequency can be used in cases of trapped twins also. So here we have the circulation of a trapped baby. Same principle, we can use it to prevent the accidents happening. Now I spoke about radiofrequency ablation. Another method we can use is bipolar cord occlusion, where we use a bipolar forceps to catch hold of the cord and again do the same thing, basically close off the circulation. You can see as it coagulates, bubbles are rising. Now we move on to using a device. So that is a shunt that we are talking about. There are various types of shunt. Now this was a patient where there was a CPAM. Earlier we saw a CPAM which was looking solid. So there we used betamethasone. Now this is a CPAM where there is a huge dominant cyst. So here we want to drain the cyst because dominant cyst can suddenly increase in size and cause mediastinal compression and hydrops. So we are putting in the needle there. This is we inserted, it's very much like a copper T insertion. we kind of push the pigtail catheter in, so you can see it slowly unfurling into the cavity, and we withdraw the stillet. There, now it's discharged. You can see the other end of the pigtail catheter, which is outside. We usually try to position it on the back of the chest wall so that the baby can't catch hold of it and pull it out, which they do. And so that's the catheter. It keeps draining the fluid, and there, that is the catheter on the back of the baby. The other methodology is fetoscope, using the fetoscopy. Now this is something that requires a little more expertise, a little more, and it is a little more challenging. And of course it is also a little more expensive, a little more in terms of risk of preterm delivery, risk of PPROM and all of those things. So these are some things which we will get into only if we feel that we really are going to, we need to weigh the benefit versus risks and then get into these things. When there is a TTTS or a twin-to-twin transfusion in a monochorion, the problem, as I said, is if one of these twins, if the bigger one dies because of a cardiac overload or the smaller one dies because of insufficient blood supply, there is patent placental channels across which either of them can exsanguinate. The normal pathophysiology, if left untreated, either one will die, and because of which the other will die, and we will lose the pregnancy 100%. So in situations like this, we try to do laser cord occlusion of the placental anastomosis. This is a scenario where we are trying to save both babies. when we do a fetoscopic cord occlusion, we are telling them we have this chance of saving both babies of around 40 to 50%, at least one baby of around 60 to 70%, and there is a chance that you might lose the pregnancy 20%. So there are various stages, and if we are in very early stages, we would not want to interfere, because all of these fetal therapy procedures, as I said, benefit versus risk. If it is a stage 1, I would still want to wait and see whether things are going to worsen. Do I really need to interfere, or do we just wait on it, try to get the baby close to 28 weeks and then hand it over to the pediatrician? So this was a case of fetoscopy. I think this was a very long video. Okay, so this is not working. So basically what we do is we kind of put in a fetoscope. So under direct vision, we see the placental bed. And in the placental bed, we see the AV anastomosis going, which are exchanging blood from one baby to the other. We identify those spots and we use a laser fiber to burn or to coagulate those AV anastomosis. And it has to be a complete procedure. We cannot leave behind AV anastomosis. If not, we will end up in trouble again. And once we do the procedure, usually there is a possibility of cardiac decompensation of one of the babies. There is a risk of abruption. There is a risk of PPROM. So all of these are important that our team as well as the patient are aware of. But if we are able to tide over the initial week or two, then the chances of both babies doing well and surviving to term is very good. And these babies, if you have a successful fetoscopic procedure, the chances of neurodevelopmental outcome is also very good, so which is heartening. And as I said, we need our team as well as the patients to be on board 200%. This is something which we have never really done, but this is coming into the country. There are a couple of centers who have done this. This is a video from the University of Leuven where I did my fetoscopic training. Yeah. So they are putting in a trocar, just like as we would do in fetoscopy. That is the fetoscope. We go in directly through the mouth of the baby, along the palate, push the tongue down, navigate beyond the epiglottis and enter into the trachea. Now in diaphragmatic hernia, a major problem is because the lung is not developing. We put in a balloon there which prevents the loss of the tracheal fluid. This allows the lung to grow and expand. And after the birth of the baby, we have a reasonably sized lung. So the chances of survival is improved. But again, like how I initially said, this is not do the procedure once and the baby is cured of diaphragmatic hernia. The correction of the repair of the diaphragmatic defect still needs to be done. After the birth of the baby, the follow-up in the NICU still needs to be done. It is just that this is a condition where if it had a 30% survival rate, we are making it a 70% survival rate. This is again something which, once we put in the balloon, the OG team needs to be available 24/7, because when we deliver the baby, we burst the balloon. That is done either fetoscopically or we use a needle and just puncture the balloon. So if the patient is undergoing such procedures, they need to understand these protocols, and this is another condition of spina bifida repair, which is what I was talking about when we are talking about hysteroscopic repair. Now even hysteroscopic repair is considered obsolete. They are doing spina bifida repair endoscopy, like using fetoscopy and biocellulose patches. But of course, our country, we haven't reached there yet. It is still a very distant call. Now, I have spoken about so many things, but the important thing here is to very carefully select those patients. One, patients and the team needs to understand what are the chances, but two, we need to weigh benefit versus risk, and these procedures can be done only and only if there is a distinct possibility of there being a benefit. I showed an example, I showed the video of the diaphragmatic hernia. We are putting a endoscopic balloon. It is very important that the diaphragmatic hernia itself is assessed very carefully. We choose those patients where the diaphragmatic hernia is not very severe, where it is not associated with chromosomal or genetic issues. Because in those babies, by changing a 10% survival to a 30% survival, we are not achieving anything. If we can change a 40% survival to a 70% survival, then it makes sense in us doing it. So all of these procedures requires very careful case selection as well as very meticulous handling of the procedure itself. So that's all I have. Thank you all so much for your very patient listening.
Thank you, Dr. Amita, for that wonderful presentation. I think from the previous presentation we dealt with early and preterm, and now we've gone backward to in utero treatments. So it tells us the gamut of technology development and what we're able to achieve with identification of diseases in utero. I remember having read in textbooks regarding the laser for TTTS and everything, and now it's becoming a reality. So that talks so much about how much advancement is happening.
I would still say the most important person in all of this is the pediatrician, no matter what we do.
Yeah, exactly. You have shown us new horizons of developments which have happened in the fetal medicine. Even though being an obstetrician, we were like, as she said, we were like reading things on textbook. Now when we see things live and you're doing it, it gives us a lot of hope to send patients to you, and women who require the treatments and the babies who can just be prolonged for some more time for our pediatric unit to take care of such babies. And definitely every pregnancy is a precious one, and for the mother it gives them a lot of hope, and that brings a lot of happiness in their faces.
Definitely.
Thank you for this
that
wonderful
making that little bit of difference is what makes it worthwhile.
Yes. Thank you for this wonderful presentation.
Thank you so much. Thank you, Dr. Amita ma'am, for such an interesting and informative session on fetal therapy.
Thank you, Dr. Amita. Recently, we have come across your patient, I think, am I right? Baby of S. Baby is doing fine, who had intrauterine transfusion with very high antibody titers, around 256 if I remember right. Baby did not require exchange transfusion. We managed with extensive phototherapy, and baby needed one blood transfusion when the baby was 3 weeks old. That's it. Baby is fine now, no more jaundice, hemoglobin is stable. Thank you.
Now I request Prasad sir, Center Head for Medicover Women and Child, to please hand over the momentum to Dr. Amita ma'am.
Pediatrics and Neonatology Department to share his valuable experience and practical insights on delayed cord clamping. Moderating this session, we have the dynamic and insightful Dr. Navita. We are excited for the discussion that lies ahead.
Good evening all. Again, bear with me for 15 minutes. It's a brief discussion about delayed cord clamping. It's a very important topic. As we all know, umbilical cord blood is baby's life, blood until the birth. It contains many wonderful precious cells like stem cells, red cells, white cells, which help in fight against infection. RBC is around 15 ml per kg, lot of iron, 32 to 75 milligrams, many stem cells, and lot of plasma for volume expansion. After birth, the uterus continues to contract and the blood continues to flow from the placenta to the umbilical vessels to the newborn for a few minutes after birth. If you look at the last part of the pregnancy, say 100 ml of blood is rotating between the baby and the placenta, 1/3 of the blood is in the placenta at any given time, 2/3 of the blood is in the baby. So say if we clamp immediately, that 1/3 we are losing in the placenta. If we delay the cord clamping, the additional blood volume which is supposed to be left in the placenta will come to the baby. So if you look at the background, the delayed cord clamping has been debated over a century. What is early cord clamping? Early is less than 1 minute. Generally we do it 20-30 seconds. Delayed is umbilical clamp is carried out at 1 minute or more than 1 minute. In early 19th century, the English physician called Dr. Darwin first described about delayed cord clamping, so way back in 19th century. As I said, first few minutes after birth, there is still circulation from the placenta to the baby. There is growing evidence, every day there is growing evidence that delayed cord clamping is beneficial and can improve the iron status up to 6 months after birth. The placental transfusion provides sufficient iron reserve for the first 6 to 8 months of life. Longer duration of placental transfusion after birth also facilitates transfer of immunoglobulins and stem cells, which are essential for tissue and organ repair. The transfer of immunoglobulins and stem cells may be particularly beneficial after cell injury, inflammation, organ dysfunction, which are common in preterm birth. There are a lot of benefits in preterms and term babies with delayed cord clamping. If you look at benefits in preterm babies, it decreases the IVS, intraventricular hemorrhage, decreases the incidence of necrotising enterocolitis, decreases the incidence of late onset sepsis, and decreases the need for blood transfusion, decreases the need for surfactant and mechanical ventilation. It increases the hematocrit, increases hemoglobin, blood pressure stabilizes, cerebellar oxygenation is good, and more red cell blood volume. In full-term infants, what are the advantages? It provides adequate blood volume and adequate iron stores after birth. It increases hematocrit and hemoglobin in term babies too. Are there any disadvantages with the mother? Then there is a delay when we go with delayed cord clamping. No, absolutely no side effects to the mother. What are the long-term benefits? In preterms, it increases hemoglobin at 10 weeks of age. Maybe it will benefit the long-term neurodevelopmental outcomes as well. In full term, as discussed before, the hemoglobin and hematocrit are more. Iron, it improves the iron content. Iron is indirectly, helps in cognitive development. Hence, it's always important to maintain good hemoglobin in infants. Anemia is not good for cognitive development. We need to balance. Should we face iron deficiency or a little bit of jaundice in newborn babies with delayed cord clamping? There are so many studies says, yes, there is slight increased incidence of jaundice in babies after delayed cord clamping, but it is not significant. Optimal cord management, that is delayed cord clamping, it reduces the death in preterm babies by nearly a third. That means it's 1/3 of babies we are doing good. Based on this evidence, the WHO recommends waiting 30 seconds before clamping the cord in preterm babies and term babies. And it clearly says immediate cord clamping is generally contraindicated. The guideline has come up in 2014. After that, American College has issued a guideline in 2017. Between the WHO and American College, UK guidelines have come out in 2015 by Royal College and NICE guidelines as well regarding the delayed cord clamping. According to WHO, delayed cord clamping is defined waiting at least 60 seconds. There are a few contraindications, clinical situations where we don't go with immediate delayed cord clamping, that is maternally when there is a hemorrhage, bleeding, hemodynamic instability, or both, abruptio placenta, fetal conditions where we don't go with delayed cord clamping is need for immediate resuscitation, placental circulation not intact, example abruption, placenta previa, cord avulsion, IUGR with abnormal Dopplers. We looked at so many clinical trials on delayed cord clamping. Many trials gives us the evidence that there is lower incidence of IVH, lower incidence of neck. Peak bilirubin levels were high in infants in delayed cord clamping, but statistically it was not significant. But severe IVH and periventral leukomalacia, there were no clear differences identified between the two groups, delayed and early cord clamping. But clearly there is evidence to say that delayed cord clamping helps in reducing the incidence of IVH, reduces the incidence of neck. Clinical trials in term infants on delayed cord clamping versus early cord clamping. Newborns infants who underwent delayed cord clamping had early cord clamping group had significantly lower hemoglobin concentrations at birth as well as at 2 days of life. In addition, at 3 to 6 months, infants exposed to early cord clamping were more likely to have iron deficiency anemia when compared to delayed cord clamping group. Maternal outcomes in review of 5 trials on delayed cord clamping. It was not associated with an increased risk of postpartum hemorrhage, not associated with increased blood loss at delivery, nor it was associated with a difference in postpartum hemoglobin level or need for blood transfusion in the mothers. There were quite a few studies, as I mentioned, one in Lancet in 2023. The studies studied on delayed cord clamping, cord milking, etc. The study provides high certainty evidence that deferred cord clamping, that is delayed cord clamping, compared with immediate cord clamping, reduces death before discharge in preterm babies. This similar effect appears to be consistent across several participant level and trial level subgroups. Another study from India, Chennai, this is again on resuscitation on intact placental circulation. The conclusion was in favor of delayed cord clamping. Delayed cord clamping with intact placental circulation is feasible and safe. That was the main outcome from Dr. Bharati Mangalabharati from Chennai Institute. Another one in 2017. Again, it supports delayed cord clamping. In Rh negative mothers, again, delayed cord clamping is good. This is a paper on multiple gestations. This is a paper from US in archives in UK journal. And the study concluded that it showed that it is feasible and safe to implement more than 30 seconds delayed cord clamping in preterm multiple births who are less than 32 weeks of gestation. Neonatal outcomes in multiples are no different from singleton. Second-born multiples have similar outcomes to first-born multiples, and monochorionic multiples did not display worse outcomes than dichorionic or trichorionic multiples. But this study also say that it needs more and more evidence to support this. Just a couple of slides on umbilical cord milking. Although it is not physiological, milking the umbilical cord 2 to 4 times towards the baby has been studied as an alternative to waiting for at least 60 seconds before clamping the cord. Many key perinatal organizations recommend the use of cord milking before clamping the cord, but only if optimal cord management is deemed not feasible. Additionally, concerns regarding the safety of cord milking have been raised. One RCT which showed an increased incidence of IVH associated in babies less than 28 weeks of gestation. An association with severe IVH has also been shown in a large retrospective Canadian cohort study of infants less than 33 weeks. So on the whole, many studies say that cord milking is not good for preterm babies. A recently published meta-analysis concluded that umbilical cord milking significantly increased the risk of severe IVH compared to delayed cord clamping group. Hence, we recommend that units should only reserve umbilical cord milking for those rare situations such as maternal collapse requiring resuscitation where cord clamping is required to be expedited for maternal safety. Thank you all, and I thank you the management, thank you the organizers for arranging this wonderful event. And when Dr. Janardhan asked me before what is the reason for good outcomes in NICU, last but not least, the very supportive management who have been helping me and my team for the past 6 years. Whatever we ask, they give me, they support. Hence, that is another reason for the good outcomes at Medicover Mother and Child Hospital. Thank you all.
Thank you, sir, for giving such a valuable insight on delayed cord clamping. And I can definitely tell after listening to the session that delaying for a minute creates a great impact on the babies. Like, more important is they will have a better neonatal transition. The baby gets some time to take the proper breath, so that with that the umbilical venous blood to the heart increases. As you already said, this will cause the maintenance of blood pressure. So this has a great impact, like it decreases the tissue hypoxia and necrotizing enterocolitis, all those. So these are more important, especially in the preterm babies.
So not only this, the long-term effects like iron deficiency, anemias, all those also can be prevented with this simple method. So more so while following this delayed cord clamping, if you are able to maintain the normothermia and able to provide basic resuscitation when the baby is at the mother end only, like providing temperature, maintaining the temperature and proper suctioning. If the baby needs any basic respiration like CPAP, can be delivered at the mother end only instead of rushing the baby to the resuscitation table when the baby is stable. And so that delayed cord clamping can be continued. But whereby we should keep monitoring the baby, and if you feel that any need is there, definitely with the team we have to take the baby with extensive resuscitation. But wherever it is needed, better to go with delayed cord clamping so that it creates a better outcome in the babies. So we at Medicover follow this, and I hope after the session that we all follow, we all continue unless there are major contraindications there. We continue. Thank you so much. Thank you. We will not take questions from the audience. Thank you, Ramdevi sir and Namita ma'am, for your enlightening session on delayed cord clamping. We will now take a short 15-minute break for refreshments, after which we will reconvene for a panel discussion based on
బ్యాగ్